So today we can discuss about the GI cancer and hematology mechanism. And I would like to invite Dr. Lokesh sir. He's an associate professor, Department of Medical Oncology, Kidwai Memorial Institute of Oncology. So to give his opening remarks, so it's over to you, sir.
Yeah, thank you. So, good evening, everyone. Welcome to the second day of ASCO 2024 updates. Yesterday, we had a very brainstorming session and also a lot of discussion about the same. So, today we are into the second day. The mainly second day, we are going through the head and neck cancer, then genitourinary, then gynecological cancer, second talk. Then comes biliary tract, then GI cancers and the hematological malignancies. So the first session, it is sponsored by Eris Life Science. So the speaker is Dr. Rajiv LK, is Associate Professor, Department of Medical Oncology at Kidwai Cancer Institute. He will be talking on mainly in relation to head and neck cancer. He'll be talking with respect to the nimotuzumab, the long-term results of randomized phase 3 study of concurrent chemoradiation with nimotuzumab versus chemoradiation alone in locally advanced squamous cell carcinoma of head and neck. And also we'll be updating few more ASCO updates. So over to Dr. Rajiv. Yeah, you can start.
Thank you, Lokesh. At the outset, I thank Dr. Lokesh and Dr. Satish for giving me the. Can you allow me to share the screen? Yes.
Yes, sir. You can.
Right. Is it visible now?
Yes, sir. It's visible.
Yeah. So fine. I will be going through some of the data of nimotuzumab. These are all some are new, some are old. So this is the first one. I'm presenting a randomized phase 3 study of the nimotuzumab. This is published 3 years back. Again, this paper is from TMH. So what they have done, they have enrolled almost 754 patients, and they are randomized into two arms. So one arm received chemoradiation with cisplatin-based chemoradiation. The experimental arm is associated with allocated with nimotuzumab. So most of the patient, those are randomized, received the nimotuzumab. So this was the analyzed. So I'm sorry for the busy slide here. So and toxicity and efficacy analysis was done. So what are the results? So you can see the results. You come to the center one. This is the results of PFS. So you can see the curves wide apart. It is the 2-year PFS was almost 50.1% in chemoradiotherapy. So compared to the adding nimotuzumab to that, it has increased another 11.8% in this with a significant p-value. And the same benefit was seen with the local regional control. Again, at 2 years, it is a 57.6 versus 67.5% with a significant p-value. There were no statistical significant of OS, even though there is a numerical benefit as seen 57.7 versus 62.8, but there was a trend towards the OS. So what they thought, they may be long-term reports may be beneficial here if you are doing that. So concluding this study, the nimotuzumab concurrent with the weekly chemoradiation therapy, it improves PFS and local regional control. And this combination is a novel alternative because most of our patients will not able to receive 100 mg of the cisplatin, which is the standard of care in locally advanced. We used to compromise and give weekly. So this may be alternative for the this novel regimen. So what is the long-term OS, which is not known? So coming to the long-term results, again, this is the study published last year. So again, this is from a TMH. This is the long-term results of randomized phase 3 study, where they added nivolumab in combination with concurrent radiotherapy along with cisplatin. So they added in the locally advanced squamous cell carcinoma of head and neck. So they included squamous cell carcinoma from the head and neck, all the region, stratified according to that, stage 3, stage 4, without distance metastasis, and those who are eligible for native CI. So this is the stratification. They are stratified according to T and N and site, and technique of radiation is also used in this. It is a 1:1 randomization. They used weekly cisplatin 30 milligram along with the RT. In the experimental arm, they added nivolumab 200 mg weekly. So the primary endpoint, what they wanted to see was 10 years of overall survival, and of course, late adverse events as the key secondary endpoints. So what are the results? The median follow-up was 8.86, and almost the primary site oropharynx constitute more than 50% cases. And what we are seeing here is the HPV was lesser. So it is only 24 patients were seen out of 269 HPV positive cancer. Coming to the results at the 10 years, so the OS is 22.5, but it was more with the adding nivolumab, almost 11% more with a significant p-value. And even the OS is also more with the adding nivolumab with a significant p-value. What we will see usually in HPV negative, even the HPV negative also, the benefit was maintained, but numerically it was lesser than that. So there were 380 patients experienced the adverse events, but these adverse events are not statistically significant. To conclude this study, addition of nivolumab to weekly cisplatin leads to the improvement in long-term overall survival in locally advanced head and neck squamous cell carcinoma without any additional increase in the late-term adverse event. And the results are largely applicable to the HPV negative patients also. This is one abstract poster presentation done this year. Again, this is from the TMH. What we usually do in metastatic carcinoma, so once we give one therapy, we stop at some time. But they wanted to see. So this was a randomized phase 3 trial, open label. They wanted to see the superiority of full OMCT to the addition of chemotherapy, that is palliative chemotherapy over chemotherapy alone. So what they have done, so in the advanced head and neck cancers, as we know, it is a poor outcome and we have very limited options. So either we go with the triple IT, I mean triple OMCT, or we go with the palliative chemotherapy for the brief period. But what they wanted to see the combining this. So they stratified according to the PS and adequate patients. So stratified according to the site of the tumor and ECOG performance. What they did, so the one group received the Acrylic carbo 3 weekly up to 6 cycles. The other group, along with this, they received triple OMCT. What OMCT they used? They used erlotinib, celecoxib, and methotrexate. Again, they used 3 weekly. It means these things will be continuous. Weekly methotrexate, celecoxib, and erlotinib were continuous. So, primary endpoint, what they wanted to see was overall survival. Coming to the results, you can see here result. The median OS is 8.3 versus 6.1, and even the PFS was more in the adding OMC. So, one important thing you can see at 6 months, the OS in the chemotherapy arm almost 50% or no more, but the same was sustained even 12 months. 12 months, only one fourth was survived in chemotherapy arm, but it was more, almost 18.5% or more. So it was a good tolerable with toxicities including fatigue and hyponatremia, which was similar to the chemotherapy harm, and a significant improvement in the physical functioning domain, the safety profile and quality of life. So what they concluded, the triple OMCT to platinum-based therapy improves the outcomes in advanced head and neck cancers. And yes, it improves overall survival with the tolerable toxicity, particularly when we are not using cetuximab or pembrolizumab. These type of regimens will be beneficial in a low and middle income group countries. So moving on to the melanoma, this is the last recent update in the ASCO. So I'll be presenting this. This is the NADINA trial. So here, neoadjuvant nivolumab plus ipilimumab versus adjuvant nivolumab in a macroscopic resectable stage 3 melanoma. This is a phase 3 trial. So I'll be telling the facts of this study. It has a significant EFS, and even this benefit is seen with the mutant BRAF also. What is the study? So, patient with macroscopic stage 3 melanoma, usually they have a bad outcome even if you give this adjuvant therapy. After 5 years of surgery, the 5 year relapse survival is only 30%, on OS is 50% only. The adjuvant therapy, what we give, immunotherapy, improves the RFS, but none of the trials shown a significant overall survival benefit, even in the long-term follow-up. Thus, this study was done. So, what is the rationale? What they wanted to see is the biological and early clinical rationale. What this is, in a adjuvant therapy, the bulk is removed. If you give immunotherapy here, what we see here, you can see the activation of the T cells. There are only few T cells are activated, so they have to work with the disease. See, if the disease is there, if you give monoclonal immunotherapy here, the T cell activation will be more. Then you remove the tumor, this more induced T cells work on the things. So this may give the benefit. The rationale was that, and they wanted to see this rationale. So this is the person phase 1 trial and swab 1801 trial. This is the phase 2 trial. They have seen this. The benefit is also seen with the SWAG 1801, almost 49 versus 72%. They wanted to replicate this in a phase 3 trial. This NADINA trial was designed. So the rationale, the optimal neoadjuvant scheme, what they did, neoadjuvant ipi-nivo, which results higher pathological response and event-free survival compared to the neoadjuvant PD-1 blockade. So reduced dosing of neoadjuvant ipi-nivo increase the safety while preserving the efficacy. And the response-driven adjuvant treatment, what they have done is the major pathological response. That is, they defined at below 10% residual viability. They have an excellent long-term outcome without subsequent adjuvant treatment. So the additional of adjuvant therapy was not uh, achieving major pathological response. It seems to improve the outcome. So this is the trial. So just see the trial design. This is a stage 3 de novo or recurrent pathologically proven resectable melanoma. At least one lymph node metastasis has taken. Additionally, they have taken other factors like PD-1s, BRAF, and stratified according to that. What they did, they give it 2 courses of ipi-nivo in one arm. Then they go with the therapeutic lymph node dissection. So once the dissection was done, they looked for the major pathological response. So if the major pathological response, that is below 10% PCR near PCR, they have not given any additional treatment. They just kept under follow. So the interval of CT for that was 12 weekly. They just follow. And if there is no major pathological response, that is more than 10% viable tumor, they started with Nivo and IPI. Uh, Nivolumab and only BRAF wild tail. And if there is a BRAF mutant, they are used the combination of tremelimumab and dapagliflozin. So this was the and adjuvant RT is also allowed in this. So in the other control arm, what they are doing, there is a therapeutic lymph node dissection. Then they started the nivolumab as a 12 course chemotherapy as adjuvant therapy. So primary endpoint of this study, event-free survival. Secondary endpoint is OS, and there are many secondary other secondary endpoint like PC, MPICR, recurrence-free, and other distance metastatic free, treatment quality of life, all those work there. So this is statistical plan. This is the power analysis and the samples like hierarchical. I will not go in detail into this. So this is the patient disposition. So there was 485 patients were screened and 423 were randomized. And in the neoadjuvant group, they included 202 patients and 211 in the adjuvant group. And most of them they received the treatment also 0.9 months. And at the time of the data cutoff, 99 patients were still on treatment. More in the adjuvant arm and only 31 in the neoadjuvant. Coming to the demography of the thing, so it is almost well matched. They have seen the age, sex, continent, and T stage, and even they have taken the lesions, ulceration is there or not, and is there is the transistors are there or not, and they have seen the number of PET positive lymph nodes also, and even the lymph nodal details, LDH, RAF mutation, BRAF mutations, from previous surgical treatment. These are all the characteristics they defined. So coming to the primary endpoint, that is EFS, you can see the graph, Kaplan-Meier graph. There's a wide apart. So almost the 12 years, it was 57.2 versus 83.7. So hazard ratio of zero point 0.2 with a significant p-value. The EFS benefit was seen almost 26%. And this EFS benefit was seen in sorry, all the subgroups. You can see most of the subgroup all benefited here. Maybe this the number is very small, only two. That's why the benefit is not seen. The overall hazard ratio is also good. That is 0.32. That is 68% benefit was seen with this. And according to the BRAF mutational status also, they looked into that. This is the mutation and this is the wild type. The same was maintained even in a BRAF mutated compared to the wild type. That is 62.4 versus 83.9 in BRAF mutated wild type. The same versus 52.2 versus 83.5. What I wanted to stress on this 83 is almost maintained with even in the mutation and wild type. As expected in the beat of mutant, the control arm was not done well. Coming to the pathological and radiological response, you can see here the major pathological response, almost 59% was seen in the central review. So the same in the local assessment also. And if you see the radiological versus pathological response, also the graph will show the bar diagrams. Coming to the relapse-free survival according to the pathological response, so the graph itself will show the better the response, the better will be the outcome. This is the 95.4. This top line is a pathological complete response, and the next line is near pathological complete response. So coming to the safety profile, so safety. So you can see the experimental arm means the neoadjuvant had little more in the thing, and only death was one death was seen in the adjuvant arm. Uh, And some of the things, for example, surgery-related complications, grade 3, were numerically lesser in neoadjuvant form. Coming to the again, the systemic treatment-related grade 3 events were seen more with the neoadjuvant. To conclude this, NADINA is the first neoadjuvant checkpoint inhibitor phase 3 trial in melanoma. The first phase 3 trial for any solid tumor testing neoadjuvant checkpoint inhibitor combination without chemotherapy, and neoadjuvant combination of ipi-nivo results in highly statistically significant EFS compared to the that is adjuvant care of PD-1 blockade, that is hazard ratio of 0.32, 68% benefit. So nearly 60% of the patients in neoadjuvant arm needed only 6 weeks of treatment. This is also one important thing. So only 60% of the patient they required only 6 weeks, and all the subgroups benefit with the neoadjuvant ipi. So concluding with all the trial with together, SWAG and NADINA defines neoadjuvant immunotherapy as a new standard of care in the macroscopic stage 3 melanoma. And it is a NADINA is a new template for the other malignancy, implementing the same neoadjuvant immunotherapy regime followed by response-driven adjuvant therapy. Because they only if the pathological response is more, they are not received the further treatment in the due course. So countries like us, so short course immunotherapy definitely benefits them even in the practical real world scenario. So it will be published in NEJM. Thank you for the patience. Yeah. I'm happy to take questions here.
Yeah, thank you, Dr. Rajiv, for an excellent presentation. I think there was a question, cetuximab versus nimatuzumab. So, what is your take on head and neck cancer?
Yes, there is no any head-on comparison with nimatuzumab and cetuximab. It is an individual preferences, what I feel.
With respect to efficacy or side effect profile?
With my experience, cetuximab had more side effects and rashes and other things compared to the nimatuzumab. Nimatuzumab patients, they fairly do well without much toxicities.
Yeah, even what we have come across is less infusion reaction we have seen with the nimatuzumab as compared to cetuximab, and also the rashes is very less. Hypomagnesemia is not seen, and even diarrhea also I feel it is very less. It's relatively very safe nimatuzumab as compared to the cetuximab. So now with the data available at the long term, I think that is also a very good option for our patients. Nimatuzumab.
Because is there in the thing.
Yes,
Any
sir.
comments on the
Because
regarding
how is
this
your experience with respect to nimatuzumab?
So I have used in few patients, especially when they are not available, like eligible for cisplatin. So I think it's tolerable and efficacy is good. There is no head-to-head comparison. So like we don't have much experience, like 50% this side, 50% that side. So difficult to comment, but it's a good option when cisplatin cannot be given. Even with cisplatin also, like we have a data, but most of the time I have used where I'm not using cisplatin.
Nimatuzumab versus cetuximab?
So, like difficult to comment on this point, sir. But I think the only problem with the nimatuzumab is it is not FDA approved, but the molecule is efficacious and potent. And we have used even during our residency also we have used in all setting, whether it's like concurrent or even in palliative settings also we have used, and we have seen a good response. So comparison is difficult to comment, but it's a good molecule to use.
Yeah,
Just keeping apart other things, the thing is how important for you to use a molecule if it is only FDA approved, or if the data is okay, you want to use.
So I think when data is there and like our country authority approved, I don't have any problem to use, sir. Rather, we should be using that.
Fine. Yeah. I don't know with the company stand, but regarding usage of the molecule, it is used widely in other countries. So not in US. US, even if you see the US literature, it will not come only.
Yes.
So the molecule is done in the well, but they are not projected in a proper platform. Maybe they should go with a multi-center phase 3 studies. That will be a beneficial. Thank you. Thank you.
Okay, thank you. Regarding melanoma, how does it really change our practice with the use of dual neoadjuvant?
No, one important thing is what I from the Nadina trial, what I understood. So when there is a disease is there, you give a immunotherapy, there will be a T cell activation is more. So they are the one, they are the defense mechanism, they act. So you remove the disease, then so when there is a response to the therapy, you not even give the further immunotherapy. That cuts down the burden for the patient also, even the cost also, financial burden also. So that is one important design. Maybe in future, in the other tumor also, they may look in that way. If there is a response is more, they may cut down in that. But coming to this Nadina trial, definitely it has done a better job compared to the adjuvant. The neoadjuvant is even the patients not achieved major pathological response also. They will give a therapy, something like adjuvant. They are also benefited with that. And this benefit is seen even in BRAF mutant also. Usually the BRAF mutant patients, they doesn't do well here, but they have done well in even in this. That is why my opinion.
Because you have any comments regarding the melanoma study?
So, like I have not used in melanoma, sir, per se, but I have used in other indications like lung or so on.
Ipinivo.
So, yeah, Epi-Nivo. So I think the toxicity of Nivo EP can be significantly reduced if we increase the duration of EP. And I think the future trial also has been designed 3 weekly to 6 weekly. Even some people are using 3 monthly EP. So, like we are very confident in using single agent Nivo, Pembro, and like I'm sure if we increase the duration of EP with Nivo, the significant toxicity will decrease significantly, and we will have much better response. And like we have a data, although very small data in even colon also MSI high patients, very good response with Nivo EP. And like last ESMO, there was a study, I'm not recollecting. They increased the EP from 3 weekly to 3 month, and they just give one dose of EP and Nivo as usual 2 weekly. There was a very good response. I think the study was in colon cancer.
Yeah, I think like Pembro also 3 weekly is there, 6 weekly is there. So even
Yes.
yeah, Nivolumab also 2 weekly is there, 4 weekly is there. Usually,
Yes.
which regimen you choose in your practice schedule?
So typically, I also see from where patient is coming to me. So like in and what regimen I am giving. Like if I'm giving with Capox, then I have to give 3 weekly. So the dose is 1.5 times of the baseline. So it is 360 milligram if you see the trials. In when you use 2 weekly, we can give 240. And once patient attends some response, then I increase 2 weekly to 4 weekly, or for Pembro 3 weekly to 6 weekly. But for initial cycle, I just stick to 2 weekly for Nivo and 3 weekly for Pembro.
You feel any difference in side effect profile by increasing the schedule duration?
So I have only three
I
patients.
don't have any experience. I'm just asking you if you have any experience
Sir,
regarding.
I have only 3 patients where I increase from 3 weekly to 6 weekly, and for Nivo I am giving monthly. So there was no side effect before also, and no side effect
Also
after
same.
also.
Okay. So same, the hospitalization will be less with the
Yes. Yes.
increased schedule. Okay. It's a good study actually with the neoadjuvant. The patient is achieving good
Yes.
response.
The only problem now that the PAP is there, like after 5 dose, it is free. So now
Yes.
sometime it may not be easy for to explain the company that I have changed the schedule, because they want signature every time.
Yeah. Practical issues, yes, yeah. Yeah, fine. Okay. So thank you. Thank you, Dr. Rajiv, for excellent
Thank you.
presentation. So now we'll move on to the second talk by Dr. Vikas, is a consultant medical oncologist from Chaitram Hospital, Indore. He will be talking on ASCO updates regarding genitourinary malignancies and also the gynecological malignancies. So over to you, Vikas.
So good evening, everyone. Hope my slides are visible and I am audible.
Yes, yes.
Yeah, so thank you, sir, for giving this opportunity. And like every time we present something and we always learn new things. So I have never say no to any such opportunity. So please do include me in any such activity, because I think that is the way, once you pass DM, that is the only way we learn in our clinical practice. So I have taken the three important abstract for this presentation. So I will start from the first one. The first one is chartered true trials. What it compared? It compared the cabazitaxel with abiraterone versus abiraterone alone in patients who has extensive disease, prostate cancer, and who has received the docetaxel. So we already know that the based on the chartered one, the addition of 6 cycle of docetaxel to ADT significantly prolong the OS, well, and compared to ADT alone in CSPC patients. And the endpoint, primary endpoint was survival, and we can see around more than a year of benefit. And the hypothesis with this, the trial was done that the docetaxel would eradicate the resistant clones already present at the time of diagnosis, thus would prolong response to ADT. Not only this, the later studies like Stampede also confirmed the same results. Then the comes high volume versus low volume. I will not go into the details, but the rationale for charted true trial is the combining a second generation AR inhibitor with a second line chemotherapy would improve the outcome by eradicating resistant clone with chemotherapy, thus prolonging the response to AR inhibitor. So what are the AR inhibitor we have? In the second generation, we have abiraterone and enzalutamide. And as far as chemotherapy is concerned, second line therapy, we are only left with cabazitaxel. So this was the treatment schema. The CRPC patients who have received docetaxel and when they were having CSPC, they were randomized into arm A. They received cabazitaxel 25 milligram per meter square every 21 days for 6 cycle, and then abiraterone 1000 milligram daily with Visalon, and arm B received only abiraterone and Visalon. The primary endpoint was PFS. Around more than 200 patients were included in this trial. The key secondary endpoint apart from PFS was the PSA response, time to PSA progression, overall survival, and safety and tolerability. The inclusion criteria: metastatic CRPC patients despite treatment with ADT. So patient is receiving continuous ADT, and then also patient is progressing. Prior treatment with at least 3 cycles of docetaxel was required. Exclusion criteria: any prior treatment for CRPCI with cabazitaxel, abiraterone, and enzalutamide. The patient should have a very good PS to include in this study, and there should be no peripheral neuropathy as the baseline, because we know that either docetaxel or cabazitaxel can cause significant neuropathy. Coming to the patient characteristic, median age was around 63 and 66. Most of the patient has good PS. Gleason score as expected, 8 to 10 Gleason score. Around 80% of patient has higher Gleason score. Coming to the time from initiation to ADT development to the development CRPC, this is very important that half of the patient is more than 1 year, half of the patient, the time duration was less than a year. Most of the patient, around 3/4 of the patient has high volume disease. Around 1/4 of the patient has visceral metastasis at the time of diagnosis. At the baseline, around 12% and 70% in Abira versus abiraterone respectively, they have underwent prostatectomy. And for radiotherapy, this number was 27.9 versus 23.2. So we can see that the patients in the both patient characteristic in the both arms was well balanced. Coming to the primary endpoint, the primary endpoint was the progression-free survival, and we can see the PFS in cabazitaxel plus abiraterone arm was 14.9 months, while in abiraterone it is 9.9 months with the hazard ratio of 0.73, the around 5 months of absolute difference. Coming to the PFS analysis by subgroups, if we see the age less than 65, 5.8% absolute difference. So let's try to find out what can be the possible patients who can benefit maximally with this combination of cabazitaxel plus abiraterone. So someone with age less than 65, very good PS, but time to ADT to CRPC less than 12 months. So when you have a patient who progressed very fast, within a year, patient received docetaxel and patient has progressed, I think this can be one of the option of combining cabazitaxel plus abiraterone. If you see the hazard ratio for from time to ADT to CRPC, if it is more than 12 months, then it is going in favor of abiraterone alone. So when you have poor prognosis patient progressed very fast, combining cabazitaxel with abiraterone may be a better option. Coming to the PSA as an endpoint, so we can see that more patient, around 90% of the patient, they have decrease in the PSA as compared to 77 and abiraterone alone. And if we see the how deep was the response, what was the nadir, so around half of the patient, 50% of the patients PSA was less than 1 in the group who received cabazitaxel plus abiraterone. Coming to the time to PSA progression, again you can see the combination group did better as compared to the abiraterone alone. Unfortunately, and it is expected, the CRPC is a lethal disease. Unfortunately, there was no survival benefit in this in cabazitaxel plus abiraterone versus abiraterone alone. But again, the study was underpowered for OS because the number of patients in each arm was hardly 100. So getting a survival with this small study may not be feasible, and the study was not designed to determine the overall survival benefit. The toxicity of cabazitaxel, we are all aware, but decreased dose, it is tolerated, especially if we give prophylactic growth factors. I think we can see the modification of doses. Around 65% patients in the cabazitaxel do the reduction was required. So like we also sometimes start with 20 milligram per meter square. But again, with this dose also around 84 patients received 6 cycles of chemotherapy. So around 77% of the patients, 2/3 of 3/4 of the patients completed all assigned 6 cycles of chemotherapy. So the conclusion of this trial that cabazitaxel combined with abiraterone significantly prolonged PS, improve the time to PSA progression, PSA response, and other endpoint. Unfortunately, no OS benefit, and there is no new safety signal. So this is my first abstract. Coming to the second abstract, which is also related to the prostate cancer. This is really thought-provoking. The information was very new to me. Hope everyone will also like this abstract. So in this abstract, I am comparing the baseline ctDNA analysis and association with outcome in Texan neo patient with CRPC treated with lutetium therapy, lutetium PSMA therapy versus change of ERA inhibitors. So I think the data of survival have already been released in the previous studies and also previous conferences. There was a significant OS benefit. Now we will try to understand what are the biomarkers. So how to select a patient for lutetium therapy in more clinical way, in more appropriate way in NGS benefit. This is all I am going to study. So I think how the randomization was there, everyone knows. Confirmed progressive MRCP patients were randomized between lutetium therapy versus change in AR emitter, abiraterone to enzalutamide, or vice versa. What they did, they collected 2 plasma sample in the patients who received lutetium therapy. First sample they collected pre-therapy. So after randomization, the first sample was collected, and second sample was collected after first dose of lutetium therapy. And they customized 585 gene ctDNA panel. They performed NGS, all sample passing QC. They try to see the association between ctDNA fraction and the outcome. What is ctDNA fraction? So we all know that in our plasma, the DNA, the circulating DNA is present, but most of that DNA, circulating DNA, is non-malignant, because normal cell also produce secretes DNA. So what they did, they try to see what is the fraction of tumor DNA as compared to the normal DNA, and they try to see what is the fraction of circulating tumor DNA. They also did association between baseline alternation that we will see in the subsequent slide. So how the baseline alteration also prognosticate that this patient can benefit or this patient might not benefit with lutetium therapy. So coming to the first sample details. So if we see the cutoff of 0.5% as a ctDNA fraction, then around 35% of the patient has less than 0.5 ctDNA fraction. Majority, around 2/3, 65% patient has more than 0.5% fraction, 0.5 as a cutoff ctDNA. The same number is also true for if we see the abiraterone also. We have seen that in the both that arm, the patient population were well matched, but here there was a difference. If we see the median baseline ctDNA fraction in the lutetium therapy, as median was 10%. If we see the AR inhibitors, the median was 3.7%. But the all patient, if we see, it is 5.9%. Why this number is important? Let's see. After receiving the first dose of therapy, the second sample was collected, and we can see that the percentage of patients who was having less than 0.5 percentage, that was 35%, and now it has increased to 62%. The jump in the abiraterone was 36 to 53%. But the question is why we are chasing this number. So if we see this curve, this Kaplan-Meier curve, that higher baseline ctDNA fraction was associated with shorter rPFS. So patients where the ctDNA fraction was less than 0.5, we can see the median rPFS, radiological PFS, was much better as compared to the patients who has baseline 0.5% ctDNA. So baseline fraction is important. The second, but again, we should not draw a conclusion that someone having higher fraction of ctDNA will not be benefited. So irrespective of fraction, the lutetium therapy is better than abiraterone or enzalutamide. But yes, the patients who has lesser fraction of ctDNA, then benefited largely. Coming to next important point, that the lower ctDNA fraction was observed in responder than as compared to non-responder. So this is not only the PFS. If we see the response rate, the patients who responded, they have a lower fraction. Now coming to the someone having higher fraction, but after the first dose of therapy, the ctDNA fraction decreases. They were able to prove that if after first cycle of therapy, if the ctDNA fraction was decreasing, it is also translate into better PFS. So this is about the fraction. Now coming to the 3 or 4 important alterations that was present at baseline. Do these, we already know that AR amplification, MYC amplification, T53 and PIK3 pathway, all these are associated with bad prognostic. So prognostic importance of these marker is beyond doubt. But what we are discussing, are they predictive? Can they predict that the lutetium therapy will be either beneficial or might not be beneficial when this alteration is present? So starting with the deletion Q amplification, which is nothing but c-MYC amplification. Again, you can see that the lutetium therapy is do much better in the patients who do not have MYC amplification. Either you see the lower ctDNA or higher ctDNA. someone with MIC amplification does well. The same is also true for AR amplification. So we know that AR amplification is a poor prognostic marker, but again, the lutetium therapy, when no AR amplifications there, PFS is 14 months. When there is AR amplification is there, the PFS, median PFS is 8.6 months. So here also, AR amplification is not only prognostic, it is predictive to lutetium therapy. The same is also true for P53. So we have seen the PFS benefit with respect all the three marker. Now coming to the response. So again you can see that the responder versus non-responder. So they do not respond. The someone with CMIC amplification, AR amplification or P53, they respond poorly to lutetium therapy as compared to the patients who do not have these alterations. So the conclusion that in patient with taxane-neo metastatic CRPC, higher baseline ctDNA fraction was associated with shorter PFS across both treatment arms. Patient receiving lutetium therapy had longer PFS compared to with ARPI changes regardless of baseline ctDNA fractions. Early ctDNA fraction dynamics, that is reduction from more than 0.5 to less than 0.5, they have some clinical implications. And about the MIC amplification, AR amplification, and P53, if they are present, lutetium therapy might not be so beneficial. But again, the data is small, and that is thought-provoking. In larger studies, and like even in choosing patient, we need to look what baseline alteration our patient is having. Coming to the last few slides, this is the third abstract. It is a phase 2 trial of pembrolizumab plus platinum-based chemotherapy as a first-line systemic therapy in advanced penile cancer, the Hercules trial. So we already know that it's a rare disease. Penile cancer is a rare disease, around 38,000 new cases per year worldwide. Our countries has 10 times higher incidence as compared to the West population. And we know that the prognosis is very poor, especially when we have a metastasis. The response to platinum doublet is very less, around 20 to 30%. The PFS is less than 6 months, 3 months to 4 months. Some people has also tried adding another therapy to platinum doublets, but I think it is related into higher toxicity rather than any change in PFS and OS. And now we see that the immunocheckpoint are coming in head and neck and other lung cancer, squamous cell carcinomas. This was a trial to see how these patients, these rare patients do when the pembrolizumab was added to platinum doublet. So patient with ECOG PS of 0 to 1, patient with planned squamous cell carcinoma, metastatic disease, either de novo or recurrent locally advanced disease, who are not available for cure surgery. They all received, this was a phase 2 trial. They all received cisplatin 5-FU plus pembro, followed by pembro maintenance for as usual 2 years. The primary endpoint was the overall response rate. The secondary endpoint was response rate by central review, PFS, OS, and safety, and so on. This is the patient population. I will not go into the details. The confirmed ORR by investigator was 40%. So from 20% we jumped to 40%. Most of the patient has partial response. But again, the point to note that even by adding pembro, around 1/3 of the patient has progressive disease. So a lot of scope for these patients are still remaining even after adding immunotherapies. This is the tumor syncrease by any magnitude was observed around 75%. But again, to say a partial response, there has to be at least 20% reduction. And we are not interested in any magnitude response rate. Duration of response, we know that some patient may respond for longer, the tail of the curve, what we say. The median duration of response was around 6 months. That median time to response was around 1.5 months. The PFS was 5.4 months. The survival was 9.6 months, again less than a year. Now coming to see some biomarker analysis. So there was 3 biomarkers they tried to see, the TMB, SPB, and the MMR. Then coming to the PDL subgroup. So what they saw that the patients with high TMB, they responds better. Someone with positive P16, HPV16, they respond better. As expected, mismatch repair proficient. This is not deficient. This is proficient, 41.4%. And surprisingly, the PDL1 scored, we see if it is lower, response rate higher. So again, phase 2 trial, we can't comment. But if you see the squamous, it is there across either in the lung or other tumor also. The PDL1 is not so important. Side effect profile, like we are already well aware. So the conclusion, Hercules trial met its primary endpoint with the response rate, overall response rate of 39.4% by investigator assessment. Overall was center review was even slightly more, 42.4%. HPV 16 positive patient, TMB high patients are potential predictive biomarker for efficacy of chemo plus ICI regimen and advanced penile cancer. This is the first trial to demonstrate the efficacy of immunotherapy in penile cancer with manageable safety profile. And with this data, the pembrolizumab plus platinum-based chemotherapy should be a new standard of care, because phase 3 trial will not be possible in seeing the rarity of this disease. So thank you so much. This is all from my side. Thank you, sir, again for giving this opportunity.
Yeah, thank you, Vikas, for a excellent presentation. Yeah, coming to your first abstract. So usually you prefer a dual agent or a single agent for prostate cancer with ADT now?
So like based on the peach trial you are asking, sir. So I have started now using for last more than a year using docetaxel and abiraterone.
So you use a combination of docetaxel and abiraterone for all evaluation.
So maybe out of 10, 7 patients I do give, and the 3 patients where I do not give docetaxel, maybe age related some side effect, or someone is very elderly, 85 years, 80 years, or some associated comorbidities where I know that even one episode of heparin neutropenia can be life threatening. Otherwise, many patients are receiving now docetaxel plus abiraterone.
You see any difference in side effect profile when you combine the both?
So side effect profile, I think not much. So the only all the side effects are due to chemotherapy. If the only thing that I do good cardiac evaluation at baseline, not only echo sometime. If non-invasive TMT, what we do with dobutamine and so on, stress test, I do before giving docetaxel abiraterone, because the only side effect I am worried about with this combination is the cardiac things. Abiraterone is cardiac, not so good.
Yeah, that is the one thing. So, do you consider using darolutamide with docetaxel, or you go with the docetaxel with abiraterone?
Yeah, so the data with darolutamide is slightly more better, but again, it's not available. But given a choice, as far as scientific discussion is concerned, the data is slightly favoring darolutamide.
Darolutamide is available. It's very expensive. So
Yeah.
that is the one that hinders us from using the same. Now, Dr. Srinivas is there. Any take? What usually you use in HSBC? Dual agent, single agent, or you'll go for newer like the darolutamide?
Yeah, as you told, I think the cost is an issue for the darolutamide. Otherwise, we would like to use the abiraterone, ADT, and docetaxel three drug regimen. But till now, I have not used any patients. So still, we are continuing on 2 drug regimen. I think any suitable patients, I think we should try on that. I think, and coming on to cabazitaxel, and I think very few patients will go on to cabazitaxel and the next line of treatment. So I think because maybe initially before availability of these hormonal agents, we were using cabazitaxel, but hardly I have used in maybe around 3-4 years second line cabazitaxel, I think most probably, because patient will not be able to tolerate by the time they progress after docetaxel. So I think very few patients I use. I mean, I don't know other our colleagues how you're.
So in last 1.5 years, I have not used any cabazitaxel.
Yeah, correct.
I have used yesterday.
Yeah, okay.
I used
Post-COVID,
yesterday.
I have not used cabazitaxel. Pre-COVID only I used to use cabazitaxel.
So after a long time, I gave yesterday. That too 40 milligram. The BSA was almost 1.9, but I was not there to give more, so I just give.
Even 20 mg per meter square was enough for cabazitaxel, I think so.
So I think now people are using hardly 20 milligram per meter square, sir.
Yeah. It's not a great drug. We don't see good responses.
But again, sir, if the patient has progressed very fast post docetaxel, we don't have much options. Like in the subset analysis, they have also shown that combining cabazitaxel plus obitrotron is better if someone has a very short period post docetaxel. If someone is progressing just 3 months or 6 months, because cabazitaxel has been designed to overcome the resistance of docetaxel. So
okay. Yeah, and coming to second abstract, how does that radionuclide therapy will change our practice? Does it really change our practice from tomorrow?
So may not be the fraction part, because I don't know how I will test that. But again, we all are using HRR panel and and NGS on the tissue. So these biomarkers can be important for lutetium, for choosing lutetium therapy. And I think lutetium therapy will come more forward and forward in coming days. Even in CSVC also, you will find that, because when the tumor volume is low, then the lutetium therapy response is very good. So the tumor fraction is high because the tumor burden is high. So I think it is thought provoking, and at least we can choose a better patient for lutetium therapy. But again, if we see lutetium versus abiraterone or enzalutamide, lutetium therapy has proven that it is better than these oral drugs.
Yeah. Now theranostics, it's moving now. So
Yes.
therapy plus diagnostic with respect to nuclear medicine. So even I think nowadays they have come up with one trial in the first line setting regarding the same. So, but the feasibility was not acceptable. So somehow it was not happened with me. So that's how the radio nuclear medicine now moving in very rapid. It is coming in the. So it was very down the line earlier. Now it's coming up and
Yes.
in the first and second line therapies, especially in prostate cancer and even in neuroendocrine tumors. It's all moving up and up now. Yeah, and regarding your third abstract, so do you really use pembrolizumab from tomorrow for all your PEMIS?
So basically, I am using pembrolizumab if it is squamous cell carcinoma histology, like irrespective of the penile or cervix. Like we know this histology appears to be benefited more with pembro. So given a choice, I think increase the response rate from 20% to 30%. We know that metastatic penile cancer is very poor outcome. So I will be happy to at least give a try.
PDL1 is not a prerequisite.
Yeah, at least in this trial, they have not shown that PDL1 is going with the response.
This trial has only a response rate data. So maybe the survival, if it comes
So
out.
they have a PFS and OS also. But again, phase 2 trial, the PFS was 5.6 month and the OS was around 9 point something.
In your practice, you do P16 for your all penile cancer?
Yes, head and neck, yes. Head and neck, cervix.
Head and neck, you're doing for all cases? For
Yes. All
cervical cancer?
Cervical cancer, we don't do much, but or head and neck, I always do.
Head and neck, okay.
Actually, my pathologist is collecting data and we are trying to collaborate with CTRT and all. Just, we have a DNB and DM program also, like, so it can be a thesis for, ENT, MS or some
so
graduate level of thesis.
So like that only I was actually planning in CS cervix a response to P16 and some chemotherapy or CTRT, but my pathologist is not doing regularly the P16 in CS cervix. So we thought of changing the topic now. Okay, Vikas. Thank you very much for all wonderful presentation and a discussion. We had a good time. Thank you very much. We'll be again keep seeing you for all the further updates in medical oncology. Thank you.
Sure, sir. Thank you.
Now we'll move on to the next session that is sponsored by AstraZeneca. So the speaker is Dr. Srinivas BJ. He is a senior consultant medical oncologist at HCG Hospital, Bangalore. He will be speaking on newer updates in the management of first-line biliary tract cancer. So over to you, Dr. Srinivas.
Yeah. Thank you. I think my slides are visible, I think, no?
Yes,
I'm audible.
yes. You can enlarge. Yeah.
Sir, yeah, it's moving now.
Yeah.
Done.
So, thanks, Dr. Lokesh and Dr. Satish, for giving this opportunity. So, definitely very thought-provoking abstracts we heard in the last session. Coming on to the biliary tract cancer, this topic on newer updates in the management of first-line biliary tract cancer. So, I think we know the burden of cancer and how aggressive is the cancer. There is almost 31,000 odd cases of biliary tract, including the gallbladder cancer, as per the national registry. And more commonly, we see in northeastern states and North Indian states. And most of them present with 90% will be diagnosed in the unresectable or advanced stage. And we can see the dismal survival, 5-year oral survival rate of these patients is less than 10%, and median oral survival is less than 1 year. We give standard of care gemcitabine and cisplatin in this group of patients. So, before going to the immunotherapy, durvalumab, which has become the standard of care now. So before that, the standard of care was gemcitabine and cisplatin. So this is the landmark study in 2010, where they have compared gemcitabine and cisplatin, and they have seen that there is a superior overall survival for this combination, for median survival of 11.7 months compared to 8.1 months for the gemcitabine alone. And even the median progression survival is also more compared to the gemcitabine alone. So gem and cis platinum continues to remain the standard of care till the advent of this immunotherapy, and with no newer therapies improving outcomes in the advanced biliary tract cancer. So I think this is one more study where they have seen even whether oxaliplatin scores over cisplatin, but overall response rate and the median EFS, event-free survival, and overall survival remains almost the same. Only thing is the side effect profiles are a little bit different. So any patients with I think lower incidence of hematological toxicities, potential use of administration in borderline renal and cardiac functions favor gemcitabine and oxaliplatin. So cardiac and renal functions are at stake, then I think we can consider oxaliplatin. So only this advantage is there when we are using either of this combination. So immunotherapy in the first line setting. So this is the Topaz 1 trial, which has come in 2022 as a landmark study with combination of the same standard of care, gemcitabine and cisplatin, and addition of durvalumab as a phase 3 double-blind placebo-controlled study. So this is a phase 3 trial in first line unresectable biliary tract cancer, locally advanced or metastatic biliary tract cancer, which include intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and gallbladder cancer. Recurrence more than 6 months after curative surgery or last dose of adjuvant therapy are also considered. And all the standard inclusion criteria were there in this study. And randomization was 1:1, and durvalumab every 3 weeks, 1,500 mg with gemcitabine and cisplatin up to 8 cycles. And if there is a good response, it was continued until progressive disease. And placebo being a placebo along with the same standard of care, 8 cycles and continuation of the placebo. The primary endpoint being the overall survival, and secondary endpoint PFS, overall survival, duration of response, some biomarker studies, and safety analysis was the secondary endpoints. So all the experimental group and placebo group were well matched in terms of the whether it is Asian patients, white, American patients, whether it is Asia, rest of the world, whether it is gallbladder cancer, intrahepatic cholangiocarcinoma, and then the locally advanced or metastatic disease. So all were well matched in the both the groups, and even the MSI status, whether it is high, stable, including the viral status, PD-L1 expression more than or less than one, almost are all well matched in both the groups. So, so these are the patient disposition. How many number of patients have received the treatment and the reasons for discontinuation. So most of the time in the experimental group, it is the radiological disease progression, and even so in placebo and gemcitabine group. And then reason for discontinuation, because of the subjective disease progression was also similar, and adverse event profile are also similar, and then received subsequent anti-cancer therapies. So most of the patients who were on chemotherapy, they have received the subsequent immunotherapy, and those who are on immunotherapy, they received chemotherapy, vice versa. So this is the result of the combination of immunotherapy and the gemcitabine and cisplatin. This is 2-year sustained and durable overall survival. So we can see here 12.9 months of median OS with significant hazard ratio. And median follow-up in months is around almost 2 years. So whether HR for HR hazard ratio at the end of 6 months was 0.91, but after 6 months it improved to 7 month. So almost at the end of 24 months, are almost the 23.6% patients were there at the end of 2 years. So almost all subgroup of patients were benefited, whether it is PD-L1 expression more than one or less than one, and then whether it is intrahepatic or extrahepatic or gallbladder cancer. So most of the patients have responded, subgroup responded to this immunotherapy, addition of immunotherapy to the chemotherapy arm. So this is the PFS curve. So here also there is a significant hazard ratio, 0.75, with a significant p-value, around 7.2 months with the immunotherapy arm and 5.7 months in the placebo group. So both OS and PFS advantage, and even the PFS. So the subgroups in PFS also were benefited, except there were some extrahepatic cholangiocarcinoma, in gallbladder cancer, where the standard of deviation or confidence interval, it crosses to this one, benefiting the but most of the subgroups have benefited this PFS advantages with this addition of immunotherapy. So significant response rate wise, also the most of the patients were responded, around 25%, 24.6% of the patients response rates were their oral response, compared to 18.1 in patient receiving only the placebo along with chemotherapy. So this is the duration of response. We can see here even after 1 year. So almost 26.1% were continued response were there, compared to only 15% in the patients with placebo group. So this is duration of response. If we come to duration of response, so we can see here the patients remaining response more than 9 months were 32.6%, compared to 25.3% in the placebo group, and the remaining response more than 12 months. So even after 1 year of, there was 26% of the patients were continuing on the immunotherapy. So that is the unique characteristic feature of the immunotherapy as a class effect. So most of the patients who responds, usually the duration of response goes to 1 year, 2 year. So that is what the biggest advantage of using the immunotherapy in most of the cancers. So a patient who responded continue to respond and beyond 2 years. So that is what this patient. So we can see here among the responders, there was a clear and sustained suppression of the curves beginning approximately 15 months after randomization. So these the upper two curves, the blue and yellow curve represent the patients with CR and PR. The blue curve is the CR and PR with durvalumab and gemcitabine cisplatin, and patients with placebo is one with the yellow curve. So there is a clear separation at the end of 15 months. Whereas patients with the best objective response of stable disease, there was a sustained response suppression even early at the 6 months. So even at the 6 months itself, we can see there is a suppression of responder or non-responders between the placebo and the immunotherapy. So stable disease patients, we can see good response and the survival even at the end of 6 months itself. So addition of immunotherapy, durvalumab to this combination was well tolerated and did not add to the safety of toxicity profile. And we have seen this in our clinical practice that most of our patients are able to tolerate this immunotherapy agent without any added toxicity compared to any other immunotherapy drugs. I think most probably any immunotherapy adverse events were 12.7%, and any grade, around 3 to 4 were around 2.4% only. So these are the different side effect profile in most of the patients. I think the anemia and other effects were related to thrombocytopenia, related to the chemotherapy, and most of the fatigue, and then the diarrhea, and then pruritus rash are maybe related to the liver function alterations are maybe related to the immunotherapy side effects. So most common grade 3 to 4 adverse events for anemia and neutropenia and decreased neutrophil count, and it is mostly because of the chemotherapy induced rather than the immunotherapy induced. The asthenia, fatigue were the common symptoms which we may attribute to our immunotherapy. So these are the immunotherapy related side effects. Hypothyroid events were more than grade 3 were 0, but any grade were around 5.9. And the pneumonitis, hepatic events, all are around less than 1% in the grade 3 events. And most of them were able to manageable. So most of the adverse events were around grade 2, grade 1 and grade 2, and which were manageable. So this is OS and immune-mediated adverse events for durvalumab versus placebo for participants with or without immune-mediated adverse events. Durvalumab and cisplatin was associated with OS benefit versus placebo, irrespective of the immune-mediated adverse event occurrence. So there are so many reports that patients who had the immune therapy related adverse events, they do better, but here they have tracked even patients without immune therapy adverse events, they have also done well in terms of the survival benefit. So this is the immunotherapy, the NCCN guideline, which is a category 1 recommendation of durvalumab plus gemcitabine cisplatin in unresectable and metastatic biliary tract cancers. And the even gemcitabine cisplatin also the category 1 recommendation, but immunotherapy addition gives OS and PFS advantage. Even the oral response rates also it gives advantage. So no new therapies for more than a decade. So since 2010 to 2023, only gemcitabine and cisplatin were there. But now the durvalumab plus gemcitabine cisplatin become the standard of care. So conclusion, durvalumab plus gemcitabine cisplatin demonstrated statistically significant and clinically meaningful prolonged OS as compared to placebo, and with gem and cisplatin. Biomarker status appear to be effective across the molecular landscape of biliary tract cancer, and patients with targetable genomic alterations benefit from durvalumab and gemcitabine and cisplatin. It is well tolerated with no additional additional toxicity to the chemotherapy. And there is a DCGI approval for this combination in India. And it is the first trial to report positive results with immunotherapy for this advanced biliary tract cancer as a new standard of care. So I think with this, I will conclude. Next slide, my talk.
Yeah, thank you, Dr. Srinivas, for an excellent presentation. In your practice, you consider durvalumab, or you consider now we have data of pembrolizumab also. So, which one you consider for your patients when it comes to
Yeah, the
immunotherapy?
long-term results data is there with the durvalumab. So I most of my experiences with durvalumab. I have not given any patients with pembrolizumab for this group of patients. I think the response rates also as in the clinical trial it is there. So we are getting the response rates and symptomatic improvement within 1 or 2 cycles of the treatment, I think.
Okay, your preference will be
Yeah, durvalumab.
durvalumab based on the evidence. So it has shown only a few months of survival benefit. So
Yeah.
still you consider for your patients?
Yeah, long-term results are required actually. Long-term results, I think we need to wait. But whatever the patients I have given, I think I am getting a good results. So in that way, so I prefer this drug actually.
Okay. So what are the molecular testing usually you consider for your patients in biliary
Yeah,
tract?
irrespective of the PD-L1 status, there is a response. So actually, in this study, they have done some biomarker status also, where HER2 and then HER2 wild type, HER2 mutation. They have subgroups are there, and most of the some of the mutation studies, there were some lesser response rate, lesser survival benefit, but they have given the explanation because of the lesser number of patients. So it is not the pre-specified subgroups. It is after post-hoc analysis. So, but most of the wild type and some of the I don't remember the genomic markers. Some of the molecular markers where there is a mutation. So there is a definite benefit with this addition of immunotherapy and chemotherapy.
You really consider NGS in all your biliary tract?
Yeah, definitely. I think HER2 new, at least I will do HER2 most of the gallbladder cancer and the intrahepatic cholangiocarcinoma patients, definitely. And though IDH inhibitors are not available, but NGS definitely, if patient is affordable, definitely I go with NGS for most of patients.
Okay. So I have not come across any patients. I have done only for a few of my patients. So have you seen any kind of NTRK or even HER2?
No. HER2 new I have seen. HER2 new and IDH positive patients are there, but NTRK I have not seen. Right.
So IDH also. Okay.
IDH, 1 or 2 patients I have seen IDH, but because of the cost, we have to import the drug almost 30 lakhs per year, per month, I think. So, I mean, inhibitor, IDH1 inhibitor, so we didn't give the patient.
Okay. So definitely that is a bit challenging. So again, getting a good amount of tissue for NGS and again waiting for the report. So
HER2, I think definitely most of, 1 or 2 patients I have treated with anti-HER2 therapy and they have done well actually. Locally advanced tumor, patient become resectable, unresectable become resectable, and the patient is still doing well actually. I have continued for 1 year and still he is doing well. So I think definitely HER2 is, I think definitely give good advantage.
HER2 is positive, you go for anti-HER2 therapy or you consider immunotherapy?
Yeah, but that time I think most probably 1 year back, I think most probably that time immunotherapy was not there. I think now I think we can add, there is a synergistic effect with immunotherapy and anti-HER2. I think definitely if cost is not an issue, definitely I want to consider. I think.
You will go for immunotherapy.
Immuno plus anti-HER2.
Immuno plus anti-HER2, first line. Okay. So we don't have data, maybe only in stomach we have data combining.
We don't have data. We have to create the data, I think.
So yeah, it will take time because R2 is not as common, maybe as seen with stomach or breast. So that is the one, maybe the reason. Because your take
Yes,
anything?
sir. So I think that TDXD is now approved irrespective of the site. If it is HER2 is positive,
Yeah.
TDXD can be given. The recent US FDA.
Yeah, irrespective of the site.
Yes.
Yeah, based on the
And
state.
I think that is the reason like we are not getting PEP now.
So
We are not
because of
able
the
to produce.
positive. Yeah. Yeah, okay. Fine. So then thank you, Dr. Srinivas, for an excellent
Thank you.
presentation. So now we'll move on to the next section. The next session will be by Dr. Tamojit. He will be speaking. Dr. Tamojit is a senior consultant medical oncologist, Department of Medical Oncology at Meherbai Tata Memorial Hospital, Jamshedpur. So he'll be speaking on ASCO updates with respect to gastrointestinal malignancy and the biliary tract cancers. So over to you, Tamojit.
Am I audible, sir?
Yeah, yeah.
Yeah. Just let me share first, sir. Just
Can you enlarge? Maybe
yes,
you
sir.
can,
Yes, sir.
you
Just
can on your video also.
Yeah. Hopefully the slides are visible.
Yeah, yeah. Right.
Yes, sir. Yeah. Good evening. So
You can switch on the video if no issues with the
just
network.
a minute, sir. There are some issues with band.
Okay, fine.
Yes, sir. Yeah, good evening. So, and thanks to the organizers, thanks to my respected teachers and mentors from Kidwai Institute for this opportunity, for this invitation. So for next 20 minutes, I'll discuss 3 landmark phase 3 trials, which are important from a medical oncologist perspective and are potentially practice changing and involve the GI cancers presented in this year ASCO. The first one is the ESOPAC study. It's a head-on randomized comparison between the 2 most commonly used multimodality protocols in resectable esophageal adenocarcinomas. So one is the and another was the cross protocol, as you all know. So basically for an locally advanced resectable esophageal adenocarcinomas, not only including the infracardial esophageal adenocarcinomas, but also the CWAT type 1 and CWAT type 2 J junction cancers. We all know the textbook approach of management is radical surgery, but to improve the local control as well as the distant metastatic-free survival, we need additional multimodality approaches. Now, what should be the ideal optimum multimodality approach in this group of patients? That is still unknown. We are still in search. And 2 most commonly used practices are, number 1 is cross protocol, the neoadjuvant or preoperative chemoradiation, as you all know, which is basically promoted by the Netherlands group. And the second one is the perioperative FLOT protocol, which is 4 cycle of FLOT regimen followed by surgery, followed by 4 cycle of adjuvant FLOT. And this is promoted by the German group. There is an US SHARE database which suggested that which patient will receive which form of multimodality therapy. It depends on 2 factors, particularly in USA. Number 1 in the whole world. So if it is an European population, then it depends on the geographic location of the cancer center. So Netherlands group always promoted the cross, and German group always promoted the FLOT protocol. And if it is in USA, then it depends on the patient is treated in the academic center versus a community-based oncology center. So community-based oncology centers, the cross protocol usage is more. In academic centers, the FLOT usage is more. So ESOPAC is basically infracardial esophageal adenocarcinomas, which are locally advanced resectable, including CWAT type 1 and 2 J junction cancers. 1:1 head-on randomized comparison between FLOT and cross protocol, given as per standard regimens. So only adenocarcinomas are enrolled, and only CWAT type 1 and 2 J junction adenocarcinomas are enrolled. That means all esophageal carcinomas, which are non-adeno in histology, either very early or very advanced stage, which are can be treated by surgery alone or not a surgical candidate, like a T1 N0 disease or T4B are excluded, and all J junction CWAT type 3 and proper gastric cancers are excluded. Primary endpoint was overall survival. Secondary endpoints are PFS, pathological stage after neoadjuvant therapy, and post-op complications. Almost 440 patients enrolled from different sites of Germany. Baseline characteristics are very much well balanced in terms of demographic parameters between the arms. The primary endpoint, if you look carefully, this Kaplan-Meier, the overall survival, which was significantly higher in the FLOT arm in comparison with the cross. The median overall survival was 37 months versus 66 months with a hazard of 0.70. That simply means there is 30% relative risk reduction of death if we use FLOT regimen in this patient population. Now, in terms of treatment compliance, almost all patients started with a neoadjuvant therapy in each group, but the completion of planned neoadjuvant therapy, the percentage is almost
Vishal, please check. I think Dr. Tamoti sir is left. So wait for 1 minute, sir.
Hello.
Yes, sir.
Yeah, any issues?
I think, sir, he's left the webinar. So Vishal will call him.
Okay. Or if Dr. Satish is ready, shall we start and then we'll take up in the end?
So wait for 1 minute more.
Okay.
If he will not join, so I will move ahead to next speaker.
Okay.
He has joined.
Okay.
Still in some network issue, maybe. Yes, fine. Tamojit? Hello, Tamojit?
Tamojit, sir, please unmute yourself.
You're not audible. Host can unmute.
I already tried, sir.
Okay.
I think some technical issue. He left again.
No, he's there.
Am I audible, sir?
Yeah, yeah.
Yeah, just a minute, sir. Just a minute. I'm
So
really
network
sorry.
is some network
Yeah,
issue.
network issue. Now,
Yeah, yeah.
probably now it will be okay. Just a minute, sir.
Okay.
Slides are visible, sir?
Yeah.
Yeah. So in terms of, so as we've seen that FLOT arm, the overall survival and PFS are significantly better in terms of post-operative morbidity and mortality. Again, numerically comparable, but 90 days mortality was higher in the cross group. So the issues are, as we all know, that this is a positive trial, potentially practice-changing trial, but the issues are during the design of this trial and during the data collection phase, the newer therapies arrived in the arena of this patient population, locally advanced adenocarcinoma of the esophagus and J junction. So one of the important trial is the Checkmate 577, which actually randomized between an adjuvant nivolumab for 1 year versus placebo in the similar population, but received a cross protocol and not achieved a PAT-CR in the surgical specimen. So as of now, the real question is, should we give nivolumab to the FLOT to the patient population who received FLOT regimen but not achieved PathCR? That is number one question. The second one is, should we extrapolate this data that the FLOT will provide an overall survival and PFS benefit in comparison to the cross protocol, particularly if the PathCR, non-PathCR population received adjuvant nivolumab? So that question is to be answered in the future trials. So the second one is again an important trial in the advanced CS stomach and CWAT type 3 J junction cancers. It's the Harmony phase 3 trial. Basically, as we all know, that oxaliplatin and fluoropyrimidine based doublet is the main landmark regimen, doublet regimen. It's the main regimen for the advanced CS stomach and CWAT type of J junction cancers. And as per the current guidelines, depending on different biomarkers, there are roles for. Am I audible, sir?
Yeah, you're audible.
Yeah, so there are roles for addition of other systemic agents. Like if it is a CPS more than 5 or more than 10, you can always add Nivo or Pembro. If it is a HER2 positive, you can add anti-HER2 agents. And if it is Claudin 18 expressing tumor, it can always add Zolbetuximab. Regarding second line, trastuzumab deruxtecan and paclitaxel probably has the most robust data in HER2 positive and HER2 negative population. The only issue is we all know that eventually all patients will progress from the first line therapy, and there is a law of diminishing return and high degree of attrition with each subsequent line of therapy. So the basic rationale or scientific basis of designing this Harmony study was that whether we can improve the survival outcomes of this deadly disease by exposing more patients to an effective second line regimen in a planned way before they actually progress. So this is basically a phase 3 randomized trial. All patients received a oxaliplatin and fluoropyrimidine doublet for 12 weeks. That means FOLFOX for 6 weeks or CAPOX for 4 weeks. And then the patients who don't progress, achieve CRPR or ST, stable disease, they're randomized to the RMA and RME. RMA is basically a second line regimen, paclitaxel ramucirumab, and RB is basically continuation of the same first line regimen for 12 more weeks and followed by fluoropyrimidine maintenance. The primary endpoint was PFS and secondary endpoint was OS and other toxicity parameters or overall response rate. Standard eligibility criteria used: HER2 negative, histologically proven gastric malignancies, adult patients, good performance score, known progressive of the disease after first line 12 weeks of platinum fluoropyrimidine doublet, and measurable disease as per the RECIST. So if we look the primary and secondary endpoint, the PFS and overall survival, with the switching to ramucirumab and paclitaxel in a planned way at the end of 3 months of first line therapy in non-progressors, it provided a significant, both statistically and clinically meaningful significant benefit in terms of both PFS and OS, with a hazard of 0.64 and 0.75 respectively for PFS and OS. But this improvement in survival parameters came at the cost of increased toxicity. The grade 3-4 toxicities are almost double, predominantly due to taxane-induced neuropathy and neutropenia and anti-angiogenic agent, means ramucirumab-induced hypertension and thromboembolism. So in conclusion, this planned early switch at 3 months of first line regimen to a second line regimen in advanced HER2 negative CS stomach patient provided important improvement of the PFS and OS, that at the cost of doubling of the grade 3-4 toxicities. The real question is whether this early switch or this strategy will provide important survival benefits in biomarker positive population. That means in a high PD-L1 CPS population or in Claudin 18 expressing population, or say, for example, like an HER2 positive population. Because as we all know that as per the current standard of care, the first line regimen, oxaliplatin fluoropyrimidine is the backbone, but you need additional systemic agents in terms of anti-HER2 agents or in terms of immunotherapy agents or in terms of zolbetuximab, provided the patient is a biomarker positive patient. And there is additional data for FGFR2 inhibitors also. So that data is still not there. So probably for the time being, this is a practice-changing trial, at least for me, but only for the patients who are biomarker negative and particularly a high volume disease, which is controlled with 12 weeks of oxaliplatin fluoropyrimidine tablet for the time being. The third trial, which is I'm going to discuss, is the EMERALD-1. It's basically, as you all know, that for a BCLC stage A and B hepatocellular carcinoma patients, the primary management is, particularly for A patients, is the surgery, either resection or local ablation or liver transplantation. And for B patient, it is the TACE. Now, again, for BCLC stage 0 and stage A patients who are not amenable for surgery, not unresectable, and but eligible for embolization. Again, the category 1 recommendation is going for
Vishal, can you please check Dr. Tamojit, sir?
Yeah, network issue.
Can we move ahead for the next session, sir?
Maybe 1 minute. Let's see. I think he will be trying to join.
Sure.
He was presenting his last study, I think. We are well ahead in time, I think. Not a issue. Hello, Satish.
Yes.
Mhm. He was not opening his video because of that network issue. So, you have called him, anyone?
Yes, sir. Vishal is already calling him now.
Mm-hmm. If he is late, shall we move on? Any update from him?
Sir, not now, sir.
Sir, he is not picking up phone.
He's not picking. Okay.
Please move ahead for the next session, sir.
Okay, fine. I think I'll find out with him. So next, I will move on to the next session. This session is sponsored by Roche. So the talk will be on polatuzumab vedotin in previously untreated DLBCL. So by Dr. Satish CT is a senior medical oncologist from HCG Hospital. So over to Dr. Satish.
Thank you, Dr. Lokesh.
just I'll share my slides. Just
Yeah.
one minute. Now I can
Visible.
the slides are visible now.
Yeah, you can.
Yes, sir. Make it full screen, please.
Just 1 minute. Okay. Good evening, everyone. Thank you, Dr. Lokesh, for this wonderful meeting from past 2 days, like yesterday and today, like covering almost the latest update. I'm going to talk on the newer molecule ADC in newly diagnosed diffuse lymphoma. That is a palatuzumab vedotin in previously untreated diffuse B-cell lymphoma. Just as we see the treatment of evolution of diffuse B-cell lymphoma in the first line, if you see from 1976, we are left with only the simple treatment with the chemotherapy, that is a CHOP regimen. Then later, like definitely this from after 20 years later, the monoclonal antibody, that first one, that is a rituximab, is made a first target therapy. It made a change in the treatment in the landscape of most of the B cell, that is CD20 positive B cell lymphomas. That has made like a lot of changes. That has become a standard of practice, R-CHOP. Later, R-CHOP has become a standard of care, from 1997 to 2022. Then later, like evolution has happened. Some slight, there are a lot of changes has happened, like in the form of R square, they try to do in between methotrexate regimen, and they try to do intrathecal methotrexate, and they try to do like even lenalidomide maintenance. Still, and even rituximab maintenance therapy didn't show any change in the outcome in the first line diffuse lymphoma. Later, like they try to add the newer ADC that is being approved, failure to the multiple line of treatment in a diffuse lymphoma. It has worked actually. It is showing almost like more than 60% they try to respond in the failure to all the line of treatment. That's what they bought in the first line. Let us see that what is the outcome if you bring in the first line based on this this regimen, polatuzumab and rituximab and cyclophosphamide and doxorubicin regimen, untreated diffuse lymphoma. It has been approved like in 2022. Let us see how it is effective in a day-to-day practice. Let us see that this molecule is a EDC, is going to conjugate it. The target is a CD79B. Can see here that rituximab is going to work on this because we are going to hit the two targets, that is a CD20 and other B cell marker, that is a CD79B. See here we are you can see that this target is this ADC is is going to come and attack on this one, and is going to internalize into those like a CD79B expressing B cell lymphoma, is going to internalize and is going to leave this because it's going to it is a monoclonal antibody, and also that drug is going to have that EDC, that the linker actually, that by lysosome enzyme, that is going to release the cytotoxic agent inside the cell, and then it's going to kill that CD, 79 expressing cell inside the cell, is going to that chemo targeted that is, this is consist of the microtubular inhibitor, because here we are not going to give the vincristine, is going to kill the selectively that internalized selective targeted cell killing here, rather than vincristine is going to kill the lymphoma cells and is going to affect the normal cells. Like is going to conjugate it with a CD like a 79 molecular antibody, that is going to via protease lives is going to cleave that the cytotoxic MMA, is going to kill that, and then it's going to have a even bystander effect, is going to kill the cells and try to have the highest possible effect cancer cell in a diffuse lymphoma. This is the one of the global that is it is published in a global randomized double-blind study that is published in a New England of Journal of Medicine. Sorry, just I'll try to connect that uh, battery the charger. Otherwise, I'll end up with the without you can suddenly shut down. Just sorry for this inconvenience.
molecule that how we should treat with the standard R-CHOP regimen. Here is like the rituximab and R-CHOP. You can see that vincristine, cyclophosphamide, doxorubicin, prednisone. Here, like what is the changes is there? Instead of vincristine, this is a polatuzumab vedotin is there. Here, like is a modified like the regimen, the replacing vincristine with the polatuzumab is done. This like almost like a 1:1 arm, that is a 400 arm patient. It's a global phase 3 data. Here, like Polarix is a study name. Like here, like Pola R versus R-CHOP in a first-line diffuse B-cell lymphoma. Here, they tried to have a untreated, newly diagnosed between 18 to 80 years of patient with the performance status like a 2 to 5. Because low risk is not involved, is intermediate high risk patients are involved here, and performance status of 0 to 5. Like stratification they are done between the intermediate to high risk, that is a 2 IPS score versus the 3 to 5, bulky disease and geographic region. You can see they randomized into 1:2 arm into the experimental arm, that is a replacing vincristine with polatuzumab vedotin versus a R-CHOP, what is our old aged the regimen with a placebo control. They're like, because no one has come to know they are giving a polatuzumab or vincristine. That's why if you are receiving the polatuzumab, they are given a placebo of vincristine. If they are receiving the vincristine, they are given a polatuzumab as a placebo. That is a placebo dose is given, so that no one comes to know which regimen, what dose they are. It is a double-blind study. Good thing they are given up to 6 cycle of treatment. And later, like a 7th and 8th cycle single agent, that is a rituximab monoclonal antibody was given. The primary endpoint of this study is PFS. Second endpoint is like event-free survival rate by investigator, PET-CR by at the end of the study by blinded independent committee review, and overall survival rate, and of course the safety is important. Let us see that like the demography and baseline characteristics of the patient in the both arms are well matched. You can see here like related to the gender and performance status, and that you can see the bulky disease almost like a 45% of their both arms are well matched. Elevated baseline, that is a LDH level, and stage wise like almost 88%, almost like near to 90% of patients that are almost stage 3, stage 4. Extranodal disease almost nearing to equal to 50%. And I said about IPS score also previously that, and ABC type. ABC type is the 1/3 of the patient, and GCP is the 50% of the patient, unclassified is 15%. And double it and treatment triplet like double expression also were included here. Coming to the primary endpoint of the study, that is a PFS. You can see here, it was like the 2 year of a follow-up. That is, you can see here like a 2 year. You can see that addition of like that is at 6.5% benefit progression free survival when compared to the old regimen, because if you is because you're having a shorter follow-up, that if we didn't follow up for 28.42 months, that's why we're having this difference. If you follow up later, you can try to have even the gap is going to become like we have to see that how this study is going to maintain that. With this, the newer regimen experimental arm that is demonstrated 27% of the percent reduction in the relative risk of disease progression, relapse, and even death compared to the older standard regimen. At 24 months VFS, you can see almost incremental, almost 6.5% like improvement in the disease control when compared to the older regimen. When compared to like not only that investigator, global I intended to treat population also. You see that here also like with the PFS along with additional follow-up of patient of a global ITT patient. You can see primary analysis and updated analysis what is published here. You can see that is almost like it is definitely is going to like reduce the risk. That is almost like increment of PFS is almost 7.7%. Anyone including intended to treat population is still is going to maintain the disease best disease control when compared to the standard regime. Let us see that refractoriness, because all regimen, all treatment doesn't work in our oncology. We will try to see that we'll have the disease doesn't respond in certain percent of the patient. Our older regimen, we try to have the refractoriness to the R-CHOP is almost like is a 29% near to 30%. with this new experimental arm, that is polatuzumab arm, you can see that the lesser incidence of refractoriness, that is almost 27.7%. Lesser incidence of primary refractoriness disease when compared to the older regimen. Coming to the secondary endpoint, that is event-free survival rate at 24 months. You can see here that is a definitely improvement in the event-free survival rate, that adding up delta of to 6.2%. It shows that it's like convincing that is going to maintain that hazard ratio was 0.75. It is significant. It is showing that improvement in that event-free survival rate. Coming to the PET scan related to what is the metabolic response at the end of study, and that this is PET scan related that at the end of study, what is how much percent of patient that are CR. You can see here at the end of treatment, you can see here CR with this the new treatment is 78%. Here is a 74%. Disease-free survival rate, you can see here like almost like you can see that the hazard ratio is 0.7. That is definitely it try to have those who have a CR try to have a disease-free survival, that disease-free survival try to be more longer, those who not achieved a CR. Definitely show that like this regimen, the polatuzumab regimen, try to have more CR and even more DFS when compared to the older standard regimen of R-CHOP. Let us see that OS data, because it is because of a shorter follow-up. We have so many molecules, even osimertinib adjuvant and even alectinib, and so on newer treatment has come. Even if you go for a new urgent setting of even double R2 therapy, so many molecules have come. Customized made treatment of those are not achieved pathological CR, adjuvant TDM has come. All the things that are shown in the improvement in the event-free survival rate and PFS actually in the pathological CR. OS data we have to wait because you have to cross more than 5 years to 6 years. Then like even adjuvant abemaciclib also, we didn't add any that survival data in beginning, actually couple of years. 2 to 3 years we were having marginal difference actually was there. I feel that is going to have a positive result. The way it's showing that, like we have to wait for the further follow up to show the difference in the OS. Actually, so far is not showing the number of increment is there, but not showing the hazard ratio is 0.94. We have to wait for the further follow up to find out that OS data. And coming to that those are exposed to this regimen experimental, that is a palatuzumab arm, they require a less number of subsequent second line, third line treatments are less when compared to that R-CHOP regimen. You can see here any number of treatment like try to be more with this first line, second line, like lowest number of subsequent treatments are more with this R-CHOP regimen when compared to the palatuzumab arm. Radiation requirement is also less. You can see here 13 versus 9.3%. Subsequent systemic treatment also less, 23.5% versus 17%. People are undergoing transplant also less. You can see that is significant, almost like it's nearing the 50% actually, and CAR T cell also less. Means like it is definitely show that is like a PFS, like if it is a PFS2, like that is try to be next subsequent treatment also less, and is going to have a benefit. Not only the first line, even that subsequent treatment also less. Coming to that risk of requiring a second line treatment after this regimen, cumulative incidence of second line treatment at 24 months. You can see here lesser with the palatuzumab, that is 17.1% versus 24.4. That's definitely shows that those who are exposed to the first line with the palatuzumab one time based regimen versus R-CHOP definitely reduce the risk of subsequent line of treatment by almost 34%. It is definitely is going to be positive, but we have to wait for some further more follow-up actually. But so far is already impressive data with the FEFS and what are the current data we are having. EFS hazard ratio was 0.66. Coming to the exploratory endpoint of subgroup analysis, if you see that, you can see that like age, definitely elder the age, the benefit is more compared to the younger age. And coming to the gender, all the subgroup they are coming towards that experimental arm, that is a palatuzumab arm compared to the R-CHOP. None of the thing is showing the R-CHOP is showing the beneficial. And it says that and ABC type, there is a worst type of disease. We see that is definitely they're going to have a more benefit in the ABC subtype. it is more positive in this high risk category of patients. If you can see here ABC subtype, that you can see that definitely you can see the graph is like wide open. You can see is very impressive thing that to see the 2-year PFS benefit with exposed to polatuzumab versus the R-CHOP. GCP is incremental thing, but not shown much difference actually. Hazard ratio was like same, but here the hazard ratio is 0.34. Unclassified, you can see here also not much shown much difference actually. Coming to the elderly subgroup, like does it like because when you're giving treatment, like everybody is worried actually when treating with R-CHOP because we cannot give a optimal dose. One is a challenge in elderly people, and also when you're not giving the optimal dose, definitely we may not have a good results. And does it make any difference by giving the treatment in elderly subgroup? Yes, you can see here like a 2-year PFS data with this polatuzumab is 77 versus 67%. Means that definitely improvement in the outcome in elderly people in a PFS rate. OS also showing, you can see here already improvement trend in the elderly people, and but you require some more follow-up because you can hear hazard ratio was 0.64 in the PFS data. OS data is immature because of the shorter follow-up. Definitely is going to have a reduction of death in the when compared to older regimen, hazard ratio is 0.74. Coming to the safety result, because that's any newer addition treatment where that you definitely will have a safety is a concern because does it make any worse in the toxicity? If you see the overall drug exposure, like I can see that the experimental arm is try to have the like with a six cycle of treatment, there is a overall drug exposure. You can see that more exposure to this newer regimen than the R-CHOP, and you can see that number of patients like gone up to eight cycle is more with this that 89% versus 86% with the older regimen. Median cumulative dose intensity of rituximab and this chemo drug regimen more with almost both arms there is 99%. There's no much difference in the cumulative toxicity of the drugs. Coming to the drugs safety, that adverse events, you can see essays are slightly numerically more, but statistically no difference actually. 34 versus 30, almost 31%. There's no much difference. Any grade almost similar. There's no much difference in the toxicity profile. Discontinuation of anything, that is almost like similar. There's no much difference. And like related to specifically this drug, vincristine versus polatuzumab, there's no much difference in the toxicity. Reduction in the drug from the study, that is even lesser with this new drug compared to the neuropathy and the thing. There's no difference in the intensity severe neuropathy when observed with this new regimen when compared to the old regimen. You can see here like a neuropathy, diarrhea, febrile neutropenia. They're all appears to be like there no much increment. Like there's a lesser toxicity compared to slight numerically. There no much difference. Coming to that overall toxicity neuropathy, you can see here like it is like they're almost near equivalent. Nausea, febrile neutropenia, and diarrhea part, you can see here like diarrhea slightly numerically more with polatuzumab compared to R-CHOP. Anemia like this slightly like this one, but there's no much when compared to the grade 3 toxicity, you see that lesser. But grade 1 toxicity slightly numerically in a few things, diarrhea slightly numerically and like anemia part, but rest of the things are almost similar. There's no much difference. Coming to the guidelines, what are the current guidelines? Okay, the data is there. This is like it has been analyzed this data very well and scrutinized, and it is made a it's come in a guidelines in 2024. Coming to the stage 1 and stage 2, excluding a stage 2 extensive mesenteric disease, like the high risk category, definitely that you are having both options, R-CHOP and polatuzumab, the arm is there. Is one of the category 1 recommendation in this. Coming to the stage 1 to stage 2 with extensive mesenteric disease, here both are preferred regimens. You can see here like R-CHOP also is a category 1, and here polatuzumab based CHOP regimen, it is there without even Christine. Other regimen also dose adjusted epoch also is there here, based on it with what subtype double it are also we're supposed to see here. Patient with a poor ventricle and poor ventricular ejection fraction is there, all the stages. You can see here we may use a dose adjusted epoch, but we are with monitoring the cardiac function.
Then other thing, rituximab, cyclophosphamide, liposomal doxorubicin can be used. This is one of the recommendation. Other thing, rituximab, cyclophosphamide, etoposide, and vincristine is there, and gemcitabine based treatment without any doxorubicin, and rituximab, cyclophosphamide, etoposide, and procarbazine based. They are category B, but this can be used. And a very frail patient, we don't have much options. Like we may go R mini-CHAP, like R-CHAP can difficult to go. These are the regimens can be followed. What is the impact of this POLARIX study? It is a POLARIX is the first trial over almost of more than 20 years to show the meaningful improvement in the benefit risk profile over the R-CHAP regimen, because we had only CHAP, then rituximab made a change, but after post rituximab, lot of permutation, combination, different things didn't show any bet. It's shown that like is better than R-CHAP as per it is shown in the international phase 3 double-blind randomized study. POLARIX reasonably accomplished the goal of treating the diffuse B-cell lymphoma by improving the disease control, avoiding the toxicity and costly salvage regimen, because the number of subsequent treatment, transplant, CAR T cells, and going for next line treatments will become less. Even though like first line will be the best treatment, subsequent treatment will be lesser when you use this regimen. The benefit of this regimen holds even more importance in the setting with limited access to the newer efficacy treatment lines in the later treatment. Should keep in our mind like this benefit is definitely even a later line also is there, but we use that first line, the even benefit is not only for a current event, even next subsequent treatment also is going to become more benefit by exposing to this newer drug. Paltusotine varantine based treatment is a category 1 recommendation preferred regimen as per the NCCN guidelines and also recommended by the NICE guidelines. It has made the impact that the change in the intermittent high risk diffuse B-cell lymphoma. I'll stop here. Any questions where we can take it. Thank you.
Yeah, thank you. Thank you very much. I think we had one question. What is the role of CNS prophylaxis with POLA?
See that POLA, like we have to take a general, what you have to take a prophylaxis routine, like intrathecal methotrexate, what is they used actually, that what are the followed. I gone through the in-depth article, that general recommendation. There are the post therapy also they have taken the that high-dose methotrexate also. We have to general what are the, we are not going to avoid like completely like CNS prophylaxis it has to taken care. You should not I have taken this new regimen. I'm completely omitting the CNS prophylaxis. It has to taken care.
I think Dr. Mahesh has answered. CNS prophylaxis is independent of POLA use.
Yes.
It has to be managed similarly as with R-CHOP.
Yes.
Mahesh is here.
Hi, Mukesh.
Hi. I think we'll panel discussion. I think we can have all this. So, okay. Thank you, Dr. Satish. We'll move on to the next one.
Only one thing about polatuzumab which we have to be very careful is peripheral neuropathy. Somebody like you have to do nerve conduction studies very often, in the sense like upfront you have to document that the patient does not have any peripheral neuropathy, and somebody who is having more than a grade 2 peripheral neuropathy forms a contraindication to use polatuzumab. And every month patient comes for pola chip, you should make sure that the patient has not developed any new clinical signs and symptoms of peripheral neuropathy. That is the most important thing. Are usually managed.
Same holds good for vincristine also, but we'll try to ignore it. That's what.
Yes.
Because like we are taking more precautions because the expensive drug when you're using vincristine will exactly lot of ignorance. Yes.
Yeah, because it is a new drug.
Yes. That's what we new drug expensive will take more precaution when you're going for vincristine, lot of ignorance.
So we are doing patients in the baseline.
So we have started for one of the patients, ABC high IPA 74-year-old gentleman. We are giving pola chip, quite a heavy man, like he weighs around 100 kgs. We are using full dose, like 1.8 milligram per kg. In general, for an average Indian adult, the overall cost of pola would come to around 15 to 16 lakhs. In addition to whatever the rituximab and the other part.
Yeah.
there are no frequent admissions, especially for this male, though he is 74, diabetic, hypertensive. We did not have any frequent admissions in between, only some diarrhea, which was pretty manageable. But otherwise, he comes for polar shift, and next time I will see him only after 21 days.
Okay.
It's quite manageable.
Yeah, further we'll discuss in the panel discussion. Thank you, Dr. Satish. Now we'll
Thank
move
you.
on to
Thank
next
you,
talk.
Mahesh.
Yeah, we'll move on to next talk by Dr. Ravi T. He'll be talking on ASCO and EHA updates with respect to hematological malignancies. Over to Dr. Ravi.
Yeah, thanks, Lokesh, and giving this opportunity. So let me share my screen.
Yeah, visible.
Visible.
You can enlarge.
Yeah.
Yes.
Thank you. Yeah. So in the next 20 minutes or so, we'll briefly discuss about new updates. Coming to the first one, tolerability and efficacy of Bricad versus Biocop in advanced stage Hodgkin lymphoma. It's a German group study, HD21, a randomized study. So the rationale for study was, we all know that escalated BCOP from the HD9 improved the PFS and OS. So we know that efficacy of BCOP is very high. Here they wanted to still further improvise on the BCOP by replacing bleomycin and vincristine with brentuximab, a CD30 targeted antibody drug conjugate. So as we all know, in this recap, what they have done is they have replaced bleomycin and vincristine with brentuximab. Chemotherapy backbone remained the same, doxorubicin, cyclophosphamide, and etoposide. And the etoposide was given for 3 days, and DTAC was given for 3 days. And the steroid dose they had reduced. So the steroid dose reduced from 14 days to 4 days, and instead of prednisolone, they have used dexamethasone. So it was a 1:1 randomization. Basically, they gave 2 cycles of Bricad versus 2 cycles of escalated PCAP, and interim PET was done. And if the PET was negative, they completed with 2 more cycles of Bricad and stopped. If the PET was positive, they gave 4 cycles of Bricad and then reimagined with the PET. And if again PET negative follow, if PET positive, consolidation RT. So the co-primary objectives was one was superior tolerability, and the second was efficacy. It was non-inferiority trial. So if you see the results, one was if you see the first co-primary objective, it was the tolerability. So the first part was met. The treatment-related morbidity, it was favoring Bricad. So there was no new safety signals apart from the peripheral sensory neuropathy, which was again expected. The benefit was observed in all subgroups. And there was significant reduction in acute treatment-related morbidity, which was clinically meaningful. So the first primary endpoint was met. And if you see whatever the side effects occurred, it resolved over time. So coming to the secondary endpoint, that is the non-inferiority. Again, it was a positive trial. If you see, there was significant improvement in the PFS at 40 months of follow-up. And the final analysis also showed the same. So it met both the primary co-objectives. One was the tolerability and the second was efficacy. So due to this favorable risk-benefit profile, the authors concluded that it is doable and individualized PET-guided Bricad as a standard treatment should be given for all advanced stage classical Hodgkin lymphoma. So coming to the second study, epcoritamab with rituximab and lenalidomide in previously untreated follicular lymphoma, followed by epcoritamab maintenance. So they published with the two arms, that is arm 6 and 7 of the study. We all know follicular lymphoma is non-curable, and rituximab-based regimens, that is either BR or rituximab lenalidomide, they are all the backbone, followed by some maintenance. Here, they want to improvise on the results. So the inclusion criteria of the study was follicular lymphoma, grade 1, 2, or 3. They mainly studied two arms. In one arm, it was a first-line follicular lymphoma, that is arm 6. And another arm was a maintenance arm, that is arm 7, after the standard chemotherapy. So epcoritamab is a bispecific antibody. It is given initially as a weekly loading dose, followed by once in a month from cycle 3 in arm 6, that is in the first line setting. And the first line setting considered RR, that is rituximab and lenalidomide. In the arm 7, it was a maintenance arm where the standard of chemotherapy was used, followed by epcoritamab maintenance. Again, first week was given as a loading dose, and from second week onwards, it was given once in 2 months and treatment up to 2 years. So the primary objective in the first arm, arm 6, was to demonstrate anti-tumor activity, that is objective response rate, and safety and tolerability. And in arm 7, again, it was safety and tolerability, followed by the number of patients who achieved CR. First, we'll discuss regarding the arm 6, that is in the first line setting. It was a positive study with very good objective response rates. High rates of patients remaining in response, and CR was seen even at the end of 18 months. And the responses were all early and durable. So it has got a very good objective response. And if you see the survival, that is PFS and OS, high rates of PFS and OS were observed at 18 months cutoff. And safety was consistent with the prior reports. There were some, say, toxicities like second malignancies and pleural effusion, which was not related to epcoritamab as assessed by the investigator. And the fatal treatment-related adverse events were very less. Mainly, it was the infection risk, since they are target CD3 and CD20, they're all bispecific antibodies. Another, this one is the cytokine release syndrome, which was low grade and manageable. So coming to the arm 7, which was the maintenance arm. If we see the results again, there were no new safety signals with the extended once in 2 months dosing. One patient had MDS, which again was unrelated to the study drug. Again, cytokine release syndrome was low grade and manageable and predictable. The onset and durability of responses was good. So many patients went on to achieve a good partial response and complete remissions also at the end of 2 years. So the conclusions of this study was, so it is a doable, that is this epcoritamab bispecific with rituximab and lenalidomide in first line setting of follicular lymphoma, which has got a good favorable long-term outcome. If you see, the objective response rate is to the tune of 95% and CR to the tune of 85%. And at 1.5 year follow-up, 90% of the patients remained PFS and alive. So 100% of the responses were converted to, partial response was converted to complete response. So this is one of the few drugs which showed this amount of responses. And even in the maintenance setting also, this drug, no new safety signals. And if you see, the PFS and OS was much better as compared to the standard arms. So coming to the third study, benefit of rituximab maintenance after the first line BR in mantle cell lymphoma. So as we all know, this was a controversial this era where if you give rituximab after BR, some studies were told that the toxicity will be high and even the morbidity and mortality was high. So this was the basic backbone, because there were again few studies which showed that rituximab maintenance after BR is doable and didn't increase the morbidity and mortality, and in fact it actually improved the survival. So this was a randomized phase 2 study of still NHL maintenance trial, which showed that rituximab maintenance after first line BR, no PFS or OS benefit observed, but it was doable. And there was some retrospective evidence which showed that rituximab maintenance actually improved the benefit. So objective of this study, it was an observation study which showed that the objective of the study was to show the benefit of R maintenance after BR. It was a large observational study. So the inclusion criteria was mainly with mantle cell lymphoma, confirmed with the translocation studies or cyclin D1 expression. And it was a first line study. So exclusion criteria were it should be in the first line. And the patient should not receive stem cell transplant. So what the authors concluded with this observation study was the event-free survival by giving rituximab maintenance is much superior even after BR. And the EFS2 also is much superior with R maintenance. And if you see the OS, this is also improved from 57% to 71%. So it was a positive study. So the conclusion of the authors were, with this large observational multicenter study, R maintenance after BR is doable, and it is associated with improved event-free survival, EFS2, and overall survival. So within the constraints of observational study, the authors concluded that R maintenance after first line BR in mantle cell lymphoma is doable, and it should be explored in the randomized study. So coming to my last update, ponatinib in patients with CMLCP and T315I mutation, 4-year results from the OPTIC trial. So this OPTIC study, it was in patients with CMLCP, where the inclusion criteria were resistant to prior to TKIs failure or patients with T315I mutation. And ponatinib was studied with 3 doses, 45 mg, 30 mg, and 15 mg. They're all randomized 1:1 randomization. And the primary endpoint was BCR-ABL-IS less than 1% at 1 year. So coming to the results, so this study was conducted in, say, with 2 specific objectives, one with patients who had failed on 2 TKs and other with T315I mutation. So this was a positive study. So if you see the PFS by mutation, that is T315I, it was positive. So ponatinib arm favored. And even the OS also by mutation studies, ponatinib arm favored. So the conclusion of the study was that ponatinib, when given in T315I mutation, it is doable, and it is one of the drug of choice based on this OPTIC trial. And in patients with more than say 2 TK failure also, this is one of the good drug we should be explored. The objective responses were assessed with long-term survival. So with CMLCP resistant to second generation TKIs and with T315I mutation. So with this, I will conclude. Thank you.
Thank you, Dr. Ravi, for all your presentation. Now we'll move on to the panel discussion. We'll have to take questions during the panel discussion. So panel discussion will be moderated by Dr. Mahesh R. is a consultant hematologist, senior hematologist at Sparsh Hospital. So over to you, Mahesh. Panelists, we are all there, Dr. Satish, Ravi, and me. Yeah.
Thank you, Lokesh, for inviting me for this wonderful webinar. A lot of updates in hematology at ASCO. I will be taking some of those important cases which have been discussed in the recent ASCO update. It is more of a case-based scenarios. Let us start with first case. We had a 40-year-old man who presented with fever, weight loss. On evaluation, he had generalized lymphadenopathy on both sides of the diaphragm. Lymph node biopsy confirms that this particular patient had classical Hodgkin's lymphoma. PET scan confirms stage 3 disease and he has intermediate IPS score. My first question is to Dr. Lokesh. How do you treat this patient? And all of you could scan this question through this QR and try answering questions. All the other people who are listening to this panel discussion could scan this QR code. You will get the questions on the mobile and start answering the questions. I'll give 30 seconds, maybe. Are you able to find the questions while scanning this QR code? Ravi? Lokesh, were you able to find the questions?
Yeah, we have questions.
Did you click on any of these options?
Yeah.
None of the people's names will be displayed. It is just
Blinded.
yeah, blinded. Okay. So let us see what are the options. Everybody, I think most of them said ABVD as an option. But we heard to Ravi's talk, and there's been a lot of debate as to whether we could stick on to the same old ABVD or we could do something different. We have our own experiences, and I think Kidwai and all oncologists may be seeing many more Hodgkin's lymphoma cases than I see, all in stage 3, stage 4, unfavorable IPS scores. We have seen that most of these patients sometimes don't do well, at least around 20 to 30% of the patients don't do well. There have been refractory cases, there have been early relapses. And when they become refractory or relapse early, the prognosis is universally dismal. So these are some of the trials. The rattle trial, everybody knows about the rattle trial. Whenever you have a patient who has a PET negative, you try to bring down the ABVD to AVD because you don't want to add pulmonary toxicity by giving more and more bleomycin. And they have seen after the rattle trial, which is a good study, they have seen that there has been no difference in 3-year progression-free survival and overall survival in a PET negative patients when they have come down from ABVD to AVD after 2 cycles of interim PET CT scan. And similarly, there have been all these were PET-based studies, and based on the PET results, they were able to increase the intensity of the chemotherapy, but that did not do much benefit when you increase the intensity of the chemotherapy with the conventional chemotherapies. As you can see here, when they increase the intensity of the chemotherapy, even in patients with PET positive, the progression-free survival is around 60%, which is not very good for young Hodgkin's lymphoma patients who could be easily cured. With the other newer regimens, echelon studies showed that the progression-free survival are not as good or maybe almost similar when compared to ABVD chemotherapy. A SWOG study compared Nivo ABD and found out that the progression-free survivals with Nivo ABD is much better than ABVD in patients with advanced stage Hodgkin's lymphoma, especially with high IPS scores. And even this LISA studies and many other studies showed that introducing a novel agents like brentuximab or nivolumab while you are treating the advanced stage Hodgkin's lymphoma could be a better option, provided that there are no financial restrictions. So now we should think somewhat beyond ABBD while you are treating your upfront stage 2, stage 3, stage 4 Hodgkin's lymphoma, especially if they have high IPS scores. What we could do, say for example, if you're starting with ABBD 2 cycles, you do a interim PET CT scan. If they are positive, as Ravi already showed us, you could straight away move ahead with BRCAD, and they have shown that the progression-free survivals and overall survivals are much better when they do this when compared to sticking on to our old practice like you continue with ABVD or maybe an escalated BCOP. However, PET negative patients, you can still proceed with downgrading the chemotherapeutic agents to 4 cycles of AVD. In IPS 3 and 7, or for all IPS scores, what you could also do is you could start with BRCAD, do a PET scan, and if they are positive, you again continue with BRCAD 4. But if they are negative, what you could do is you could either do BRCAD into 2 or AVD into 4, followed by PET CT scan. Now, you can do away with PET CT scans, or maybe you can just monitor with the PET CT scans when you are using a Nivo-based chemotherapy for advanced stage Hodgkin's lymphoma. Nivo with AVD or brentuximab with AVD are quite a good options for when you don't have to actually change the protocol based on the interim PET CT scans. Now, Lokesh, what you would do, whether if there are no financial restrictions, whether you would stick on to the same ABVD or would you like to do something differently?
Yeah, it depends on the IPS score. So
Yes.
if it is IPS score less than 3,
Yeah.
go ahead with the ABBD, which I am very happy with
Correct.
many
Yeah.
years. So
Yes.
we have seen with our eyes, we have very good experience
True.
with
True.
ABBD. I'll go
Yeah.
ahead with ABBD 2 cycles, then do the PET reassessment, look for
Mhm.
the PET positivity versus negativity. If negative, I will de-escalate to ABD for remaining of 4 cycles. So if positive, that is a question. So earlier we were thinking of escalated BA-COP. So now
Okay.
things have changed.
Change. Yeah.
I have not
Probably.
seen escalated BA-COP any of options here. So is it
Yes.
really not an option but present?
True.
Okay.
Okay, I think that's a good answer. You can straight away start with ABVD, and maybe an interim PET CT scan will help us to integrate the novel agents with the other chemotherapies. Like BRCAD is one good option, and Nivo AVD is also one good option. And definitely, as you can see here, with the novel agents, you can see progression-free survivals which are much better. Especially, you can see with Pembro AVD, the median progression-free survival was not reached, and a 2-year progression-free survival was as good as 100%, which were not reached with ABVD. And maybe more studies on these novel agents would throw a light, and probably in coming years, it would change the way the Hodgkin's lymphoma, especially the advanced Hodgkin's lymphoma, would be treated. And Pembro is not that costly a drug. Probably for 4 to 6 cycles, it would cost around 6 to 8 lakh rupees, which most of
Yeah.
Indian patients these days
I
would
think
afford.
Pembro or even Nivo will take over first line
True,
all
true.
Hodgkin's disease advanced because
Okay.
excellent responses and
True,
survival.
true. Yeah.
So long-term data, I think that may
Mhm.
be the hope for us.
So as Lokesh said, we also used 2 cycles of ABVD for our patient. Interim PET CT scan was negative. Received 4 cycles of ABD. As per the rattle, they have seen that you can, if the interim PET CT scan is negative, you can come down from ABVD to AVD with the progression-free survivals on par with 4 cycles of ABVD after the interim PET is negative. 4 months from the chemotherapy, patient presented with the upper back ache. On evaluation, he was found to have a relapse of Hodgkin's lymphoma in the thoracic vertebra, which was proved by the repeat biopsy. And the repeat biopsy is very important because sometimes we had a patient who came with generalized lymphadenopathy after treatment for a Hodgkin's lymphoma. I was very much sure that this is going to be a relapse of Hodgkin's lymphoma, but a biopsy turned out to be a tuberculosis.
Tuberculosis.
Yeah, what next for this patient? Ravi, would you consider the same old salvage chemotherapies like ICE, GVD, whatever, GDP, or else would you do something differently for your patient, considering that this patient has relapsed within 1 year, and people who relapse early in Hodgkin's lymphoma do not usually do well?
Yes, sir. Basically, our intention would be to give a salvage chemotherapy and to have good response followed by stem cell transplant. So, considering our experience and what we are comfortable, we use one of the salvage chemotherapy. Preferably nowadays, we use a lot of this brentuximab-based chemotherapy to achieve good response. Then transplant it followed by maintenance brentuximab.
Correct. So that is one of the options. So there are two kinds of novel agent-based salvage chemotherapies: brentuximab-based salvage chemotherapies and anti-PD-1 based salvage chemotherapies. Good progression-free survival rates in all patients without transplant, and definitely so with autologous stem cell transplant, which were never achieved with the conventional salvage chemotherapies. These numbers with conventional chemotherapies was in the range of 40 to 60%, not more than that for these kind of patients. There is a head-on comparison between Pembro GVD versus brentuximab ICE. Pembro GVD versus brentuximab ICE. Pembro GVD was found to be a little bit superior when compared to BV ICE. The degree of severe neutropenia was higher with BV ICE, and also the degree of neuropathy was significantly higher when compared to Pembro ICE. So after looking into the detailed literature and based on the recent ASCO 2024 update, for this patient, we chose to give Pembro GVD, and he has received one cycle of Pembro GVD. And there's a lot of support for Pembro GVD especially for Pembro, especially from MSD, and they have been giving us good patient support with the free vials. If you buy one, you get one free vial. And per cycle, Pembro cost would come down to around 2.15 lakhs. And definitely this patient, what I mentioned, is going to receive Pembro GVD 1 to 2 cycles. Go ahead with the autologous stem cell transplant. And finally, he would also go on to receive maintenance with pembrolizumab for at least 18 months. That is what we intend to do for this particular patient.
With the use of immunotherapy, you see any difference in, say, toxicity of
Yes, correct. So definitely that's a very important question, because all these anti-PD-1 based salvage chemotherapies would increase the risk of peri-engraftment syndrome. Whenever the stem cells engraft, they release a lot of cytokines which can cause lung injury, and patients sometimes develop respiratory failure. These chances are more with anti-PD-1, but can be easily managed. What we usually tend to do is, whenever patient engrafts and develops a little bit of a signs of peri-engraftment syndrome, we immediately start them on methylprednisolone. So that is one important complication we see when we start these patients on anti-PD-1 based salvage chemotherapy.
Okay.
Now, this is again one more interesting patient. This question is to Dr. Satish. 72-year-old presented with fatigue, recurrent fever. CBC revealed a hemoglobin of 7 grams, total count of 2,500, platelets of 25,000. Bone marrow aspiration showed 80% myeloblasts, which were confirmed by flow cytometry. Molecular prognostication panel revealed that this particular patient has IDH1 mutation. How do you manage this patient, Dr. Satish? And I hope that these days oncologists also manage with the change in treatment algorithms. Probably a lot of AMLs also have been managed quite well with the medical oncologists. How do you manage this patient?
Yeah, like this elderly AML patient, definitely like chemo-free regimens. We'll try to see mainly that we'll go azacitidine like azacitidine, like any one of the regimen that we used with ventriclox. This is based on the patient, because affordability is a major issue for even for ventriclox. Mainly we try to go with these agents, and definitely the newer novel agents like targeted, like because like now molecular profiling, because NGS is doing in even AML also now. Based on that one, definitely the targeted agents like can be added, but the problem is the cost is a major issue in our patient. Like based on that, we try, mainly our practice majority of the patient is mainly will go with the like azacitidine or desacetyidine, and plus or minus ventriclox. This is our practice. But prognosis not good. Like it's definitely that what we used to have 5 years back. Many time we used to send home like only palliative care with blood transfusion, symptom and treatment. From past 5 years, like definitely the treatment modality has changed, even including hematologist and medical oncologist. Definitely they try to go for at least palliation of treatment with at least longer duration of treatment. Maintenance we try to do. Hello.
Yeah, I'm listening.
Yeah.
Correct. So what we have been doing is most of the times, yeah, with azacitidine and venetoclax coming into existence even in India, I think most of these patients with AML can be smoothly handled, and we have been handling a lot of these AML patients even in distinct places. Some of the patients are receiving the induction chemos under my guidance even in distinct places. And the toxicity is pretty well manageable. We, of course, tell that the mortality rates would be around 10 to 20% and take it forward. What we have been doing for all these AML patients, whenever we have made a diagnosis of AML with whatever is stratification panel, you could either admit these patients as an inpatient or an outpatient. You could treat him. Antimicrobial prophylaxis is very important, mostly antiviral and antifungal. Most of my patients are on posaconazole prophylaxis. They don't get any antibiotic prophylaxis because of the resistance pattern in India. Very often, we should bring down the count to less than 15,000. In India, we try to bring it down, and my practice is to bring it down to less than 15,000 with hydroxyurea therapy before you start venetoclax. The reason is the risk of tumor lysis syndrome is very high when you start these patients on venetoclax. All your patients will receive hypouricemic agents, either allopurinol or rasburicase. Good hydration is very important, at least 3 liters of IV fluids. And of course, initially, since the patients are admitted, they will require IV hydration at a rate of 3000 ml per square meter. Now, coming to AML, the dose of venetoclax, I don't increase from a low dose to a higher dose. Most of my patients get 100 milligrams to start with, and that is the dose they receive uniformly throughout for the first 3 weeks. Most of my patients are on strong CYP3A inhibitors like posaconazole. That is the reason we stick on to a dose of 100 milligrams and we don't increase beyond 100 milligrams. And what has been our results? We have used this combination for at least around more than 50 patients, and at least 80 to 90% of our patients have gone into a morphological remission and even a MRD negative status. And the mortality is very, very less. I can say around 5%, unlike 7+3 chemotherapy. And usually after 5 to 7 days, patients are discharged and they are managed on a OPD or maybe on a daycare basis. And definitely this is one thing which all the medical oncologists could look for, because this is most often now AML is a daycare practice, especially. And also even in young patients, considering that the results with AZA and venetoclax have been so great, we have moved away from 7+3 chemotherapy and we have been using AZA venetoclax even for young patients to achieve morphological remissions and also MRD negative status. Now, once we do a marrow at day 21 after we have started azavenetoclax, and at day 21, if the patient is in morphological remission, hold venetoclax, give GCSF, and once hemoglobin, white cell, platelet counts, everything improves, we again repeat a marrow. And if they are not affordable, if we may skip this marrow and straight away go with continuation phase of azavenetoclax. And during the continuation phase, we may reduce the dose of venetoclax to 14 days or sometimes even to 7 days. And also azacitidine, in a long run, we may reduce it to 5 days rather than giving it 7 days. And we may also increase the duration. Say, for example, we start doing it every 28 days. Later on, we do it every 35 days, 45 days. Some of my patients have been receiving it every 60 days. We have had a couple of elderly patients, even at the age of 85 years, we have given this treatment. He's taking a treatment for almost like 3 years now. He still continues to be in remission. Now, the other question which I asked was, what do you do with the patients who relapse? Ravi, what do you do with the relapse patients in this patient? This patient relapsed after 2 years of treatment. He continued azavenetoclax for 2 years, and after 2 years, he relapsed.
Yeah, elderly, I really feel difficult to give any strong salvage, and I don't have any backup. So many of the time, actually, frankly speaking, I go for palliative care.
Yeah, yeah. So now this particular patient, as you can see here, has got a IDH1 mutation. This IDH1 mutation is targetable. We have this molecule called as ivosidenib, and ivosidenib is available through black market. I shouldn't be saying this here. And the cost of monthly therapy would be around 45,000 for ivosidenib. It is an indefinite therapy. Patient continues it forever, and sometimes we may add AZA or venetoclax, or maybe if you have started the patient on AZA, we may change it over to decitabine. We have one such patient who relapsed, and he still continues to be on ivosidenib, and he's doing well as of now.
What about we have glittertinib available now? Can we use
Pardon?
it?
Pardon?
Glittertinib.
Giltertinib, we don't have it. I haven't used it in my practice. And most often when we are using venetoclax, we don't have to use gilteritinib. And this particular patient does not have a FLT3 mutation. So obviously it is out of question here. But of course, gilteritinib is one of the important mainstays of treatment while the patient is having FLT3 mutation, and it can be given as a maintenance therapy after patient has completed a chemotherapy. Any further questions on this question?
Yeah,
No.
that Mahesh. Yeah, no,
Yeah.
no, no. That FLT3 inhibitor, like yeah, that's what a baseline you'll have a stratification. Even though elderly will try to go,
Yes.
most of what you said is rightly that like you will go venetoclax and
Yes.
azacitidine.
Mm-hmm.
But based on the molecular profile, we try to decide like azacitidine. But problem is black market. Like if you come to on like is if you come to like insurance patient, all those things, I don't know.
So
But like
insurance
we
people now
yeah,
venetoclax is available through hetero also.
this is
It is
like the previous challenge about even ventriclax also all black marketing medicine that we are little
Yes,
bit
now
worried actually
true.
that people are like they're selling Bangladesh medicine, all the thing. That's
No,
what
yeah.
that was one concern
So
actually.
we
And
actually
even nowadays they're telling even availability of no, Mahesh, like what is like right now challenge is outside black market. They're telling all they're recently they got told Delhi, they're telling they're without drug they're selling actually black market. That's what we don't know how to trust because all patient risk we have to tell you can bring and you take treatment as all your risk. If you we recommend there's a major issue. And
yes.
one thing I wanted to ask you is how about oral azacitidine? Do you practice oral
No,
azacitidine?
never. I never do. I have never given oral azacitidine. Even as a maintenance, I fail to give oral azacitidine. One, because when compared to subcute AZA, oral AZA, I found more GI side effects. That is one part. The second part, in the early part of my practice, few of my patients wherein I changed from subacute ASA to oral ASA relapsed for unknown reasons. Maybe because of that, I have a little bit interest to use the oral ASA in my practice.
Yeah, that
And the same experience other hematologists also had while giving oral ASA for patients as a part of maintenance.
yes, yeah, concern about GA toxicity with oral ASA,
Yes.
but otherwise the mainly difficult like whether maintenance therapy that people are localized they can come. Those are practicing district place, all those things. Whether if the tolerable patient can you maintain an oral ASA? That's what.
Yes. No.
Yeah, because that efficacy wise is not much great difference actually.
Mm.
That's
And
what. Okay, that's
subcutaneous
one.
ASA, most of my patients are happy because they take it once in 35 days, 45 days. It's already easily managed. Already they have gone through it. Why unnecessarily change the protocol? And when the patient, either way, this is all maintenance. And you don't know when the patient relapses. And if it is happening during the time when I change it from subcutaneous to oral ASA, they start blaming me.
Okay. See, you said about relapse actually that ASA to the desacetidine and change of other molecule. That's fine. But do you practice the low dose RSC anything?
Low-dose Sarasi only as a
Palliation.
palliative
Palliation.
regimen.
Palliation. Yeah.
Yes, low-dose Sarasi
Even
just.
other. Yeah, even other modality has a palliation, but like sometimes like cost is a major factor, and elderly the people family interest also not there much.
No,
That's what like
the
that
good
some
thing
patient
about
we
this.
practice. Yeah. Low dose RSC sometimes we
Yeah.
practice.
The good thing about these medicines, no, these targeted therapies like ASA, when Eversedinib, their quality of life is much better because they go into remission for quite a durable period of time. I have seen my own patients after receiving this therapy, they have gone to Singapore, they have been having a good quality of life, they have been enjoying the life. So all these are there.
Sorry to interrupt,
Yeah.
sir. Please conclude.
Yeah. Should I continue with the next question?
Continue.
Yeah.
Sure.
Now, this is again one of the interesting topics for most of the medical oncologists. A 48-year-old female presents with backache and fatigue. On evaluation, CBC hemoglobin showed a 9%. Total count was normal. Platelets were normal. Calcium was high at 12 grams. LFT showed increased globulins. Myeloma protein panel revealed 5.4 grams of MBAN, increased beta 2 microglobulins, and bone marrow aspiration showed 67% plasma cells. So this question is to Dr. Lokesh. How do you restratify your myeloma patients, whether you have with the recent guidelines,
Yeah, I
especially the
think
ASCO
we were all using
2024, have you
albumin
changed
and
the way you practice or whether you stick on to the same ISS restratification panel or you do something differently? How is your practice now? How do you restratify and counsel your patients?
yeah, all these days we're using serum albumin and beta 2 microglobulin as low, intermediate, and high risk. Then now we have again with the availability of cytogenetics with that high risk, I think with the LDH we can go for revised IPI scoring. So again now we have R2 IPI scoring has come now. So I think that is incorporating the ISS scoring 2 and 3 with some points. Again, the iris cytogenetics with some point with the LDH. So that is the revised one. So again, it will divide them into the 4 groups: high, low, intermediate, and again low. So still I have not done this. Still I am going with RIPI. So maybe the further patients I need to consider for R2 IPI.
So this patient has monoallelic P53 mutation, translocation 414, and increased LDH. What is the risk for this patient?
So, okay, this is increased beta 2 microglobulin. It will be ISS 3. Albumin, okay, fine, I'll take it ISS 3. I think then.
Based on the fish studies, based on the genetic panel?
I have to see that scoring exactly based on some points.
So
If it
I
is
think
ISS 3,
nowadays
it will
this
be.
genetic panel is very important. You could just remember this diagram, only there are few things which are good in myeloma. What is good? 11-14 is good. Hyperdiploidy is good. Only these two things are good. Rest all is bad. Rest all is bad. As you can see here, biallelic TP53 mutation is very bad. Multi-hit myeloma. If your patient has P53 mutation, deletion 17p, or any of these starting with 4, 14, 14, 16, 14, 20 are definitely bad. Gain of 1q is bad and deletion 1p is bad. And if the patient is having more than 2 of these abnormalities, you can see that they are considered as ultra high risk multiple myeloma. Universally, these patients do really very bad, and whatever you do, the chances of relapse is very high. And in addition to that, if your patient has got an extramedullary disease, that is a plasmacytoma other than the bone marrow, they behave badly. And of recently, we have not been doing it in India. High gene signatures, those are bad. If you are finding a circulating plasma cells, even if it is more than 2%, if your pathologist says that he is finding 2% plasma cells in the blood, that is definitely bad. And more than anything else, if your patient is relapsing within 12 months of therapy, it is the worst thing to happen, and these patients definitely do not fare well. High risk, all these mutations, other than translocation 11, 14, if they are occurring isolated, are high risk myelomas. Even here, you can see that when you move away from standard risk to high risk, the overall survival is measured only in months. And that is why it is very important to identify these high risk and ultra high risk myelomas. And my patient who has a ultra high risk myeloma because he has got 2 mutations. He had deletion 17p and he had 414 translocation. That means this particular patient was a very high risk multiple myeloma. And there are various risk stratification panels. What we have been following is in our center RISS, and of course there is something called as M-Smart by Rajkumar et al. Group, and there are various other groups looking into various risk stratification panels. But what we stick on to is a RISS panel. All multiple myeloma patients with the first draw of the bone marrow, you should always collect a sample in sodium heparin and always get a fish for multiple myeloma panel, because that is definitely going to tell us whether your patient is going to do well or not with the therapy. And when you do a fish, you are looking for all these mutations, the translocations and the genetic other deletions, and of course, whether the patient is having trisomies, we are looking for those mutations. Now, what is ultra high risk myeloma? I already told you, somebody having a biallelic TP53 mutation, somebody having more than 2 high risk cytogenetic abnormalities, somebody having a high gene expression signatures, somebody having an extramedullary disease, somebody who has got more than 2% plasma cells, and having a primary refractory disease, or who is relapsing within 12 months, they fall under a bracket of an ultra high risk myelomas. And these patients definitely do not do well when you start the therapy. Now you have this patient with a ultra high risk myeloma. How do you treat this patient? All of you with your mobiles could scan this QR code and start answering this question. My options are triple chemotherapy followed by prolonged maintenance with lenalidomide, triple chemotherapy followed by autologous stem cell transplant followed by maintenance with 2 drugs, quadruplet chemotherapy induction followed by consolidation followed by maintenance with single agent bortezomib, quadruplet induction followed by autologous stem cell transplant followed by consolidation followed by maintenance with 2 or 3 drugs. Everybody answered the questions? Shall I move the slide?
Yeah.
So everybody answered the question, quadruplet induction followed by autologous stem cell transplant followed by maintenance with 2 or 3 drugs. That is the right answer. We have to be doing for all the ultra high risk myelomas. You have to do a quadruplet induction with daratumumab. Autologous transplant is a must for all these high risk and ultra high risk myelomas. The only place wherein you can avoid autologous stem cell transplant is patients who come with a standard risk, because definitely the autologous stem cell transplant is going to improve the progression-free survival. All your patients after an autologous transplant should receive consolidation with the same quadruplet therapy for at least 4 cycles, followed by not a single main agent maintenance, but with either 2 or 3 drug maintenance. And that is what most of these trials have shown. Cassiopeia trial with the DARA VTD, Griffin trial with DARA VRD, Persuas trial again with DARA VRD, master trial with a single uh, line treatment, that is DARA KRD, ISKIA trial with isatuximab and KRD. All these have clearly shown that quadruplet therapy has increased the progression-free survival, as you can see here, and even the MRD status has been quite good. Achieving MRD negativity has been quite good when you are using a quadruplet therapy when compared to triple therapy. And of course, all these patients went on to receive autologous stem cell transplant followed by prolonged maintenance therapy.
Last 2 minutes, Mahesh.
Yeah, yeah. And same thing holds good with the other trials which have been done uh, for the ultra high risk myeloma. For this particular patient, quadruplet induction, autologous stem cell transplant, consolidation, followed by maintenance with at least 2 or 3 drugs. Now, coming to the last case here, a 48-year-old man presented with enlarged lymph nodes in left neck and right groin, measuring up to 2 centimeters. He was asymptomatic and had no evidence of these symptoms. Lab results normal. Biopsy showed grade 1-2 follicular lymphoma. PET CT scan revealed the same. There was no splenomegaly. Bone marrow biopsy showed trilineage hematopoiesis. This particular patient had a stage 3 FLIPI score 1 follicular lymphoma. How do you treat this patient, Dr. Satish? Whether you would wait, whether you would give R with monotherapy, BR, R-CHOP, what would you do with this patient?
Sorry, that is what is the diagnosis of patient?
Follicular lymphoma, no symptoms.
No symptom. I'll go for R monotherapy. R monotherapy.
R monotherapy.
Yeah.
Dr. Ravi?
Yeah. Even watchful waiting also will be one of the options.
Yeah. Both are quite a reasonable options. Either R monotherapy if somebody is quite worried about the lymph nodes in the neck for more of a cosmetic reasons, but definitely it is not going to improve the overall survival. What I would also have done is a watchful waiting. There are so many new drugs which have come in the treatment of follicular lymphoma, like PI3 kinase inhibitors. If somebody is EZH2 positive, tasmetostat, antibody drug conjugates, which already we discussed, polatuzumab. BiTEs are the new molecules which have been used, which target T cells with the anti-CD20. And of course, CAR T cell therapy, not much of success with follicular lymphoma, but great success with other malignancies like DLBL and mantle cell. And of course, you would do a watchful waiting. Now, 2 years later, patient presented with enlarging lymph nodes in left neck. He was anxious, mild fatigue. Lab results were normal. A biopsy returned to be a follicular lymphoma. And this particular patient went on to receive 4 doses of weekly rituximab. Now, again, after few years, he presented with rapidly enlarging lymph nodes. Now, the follicular lymphoma has transformed into GCB DLBL with MYC40, BCL2 more than 50, MYC translocation negative. Ki67 grade was greater than 90%, and IPI score was more than 5. Definitely now he has got a double hit lymphoma transferred from follicular lymphoma. Dr. Lokesh, what would you do in these kind of scenarios wherein your patient who had a follicular lymphoma, what
This
are
is
your
the
options?
double hit. The fish was positive for.
Yeah,
Okay, so double hit lymphoma needs intensive therapy. So usually I'll go ahead with the RDA epoch.
yeah, that's the right answer. So somebody who has got double hit lymphomas, we know that DR and RSHA would be suboptimal. This particular patient went on to receive DA epoch. He also received CNS maintenance because he was high risk for CNS relapse. Due to time constraints, I would stop here. With these questions, I can take it in
Okay.
probably next webinars.
Yeah, I
Whenever.
think we have done extensive discussion. Hematology is very difficult to complete over 1.5 hour. We have covered most of the things, I think, in this ASCO. Whatever the updates, I think that is good enough for us. Fine. Thank you, Dr. Mahesh. Thank you very much for an excellent panel discussion. We had a very good discussion with all the recent updates. So thank you very much. Thank you. Now,
Thank
Dr.
you.
Tamojit is online. Tamojit, are you there? Okay, fine. So I think I'll next move on to the my talk. That is the practice changing updates in this ASCO. So what are the 10 changes that I will do from tomorrow after attending this ASCO? These are the few studies what I will do after attending the ASCO. So I'll just briefly go through the all. So the first and foremost is the LAURA study. So we know that osimertinib is a wonderful drug for all our patient with stage 3. I'll do my EGFR and I'll start with osimertinib indefinitely till the disease progression. It has a PFS benefit of 39 versus 5 months, almost 34 months, 33, 34 months benefit with respect to progression-free survival. And there is a trend towards overall survival that is awaited. We may not expect because of crossover. So this is a practice changing study for us for all stage 3 EGFR mutated NACLC post CTRT. So next is a crown study. It is lorlatinib versus crizotinib. So again, the same drug crizotinib, the lorlatinib has beaten again, similar to what the ceritinib or the alectinib or brigatinib has done. So with the 5-year PFS, it was 60% versus 8%, and 5-year it was not reached for the lorlatinib. It's an excellent responses or survival now at present. We have the best responses or survival at present we have for the all positive NSCLC. So, and also there is a longer time for intracranial progression with grade 3-4 adverse event that we need to keep it in mind when we manage with lorlatinib. Then Adriatic study, it is a small cell lung cancer. Post CTRT, the durvalumab maintenance. This is again a practice changing with PFS benefit of 9 versus 16 months and overall survival benefit of almost 22 months, 33 versus 59 months. So with some adverse events management with respect to immunotherapy, these are all manageable. We all are experienced with the management of the immunotherapy related adverse events. So this is again one practice changing study from tomorrow. Again, the post-monarch study yesterday discussed by Dr. Satish with the use of abemaciclib with endocrine therapy after the patient progressed on CDK4 inhibitors. Again, the PFS benefit of 3.9 versus 5.6 months, 2 to 3 months benefit. Again, we consider adding abemaciclib in the second line, the patient who progress on CDK4 along with fulvestrant. So the Destiny Breast 06 study, it's again the TDXT, it's a very well-known drug now. So it has done a very good job for all our HER2 positive patient. Not only that, now HER2 low has come. So in this Destiny Breast 06, the HER2 low expression, they are randomized to TDXT versus chemotherapy. Even around 18% of the patients were ultra low, that is HER2 expression of 1 to 10%. It is showing a good PFS benefit of 8.1 versus to 13.2 months with TDXT group. And also there is a good overall response rate of almost 25%. So again, the similar findings were seen in ultra low group. That is very important. So major chunk of patient, I think, can receive that TDXT in our practice at present are too positive or too low, ultra low. So except HER2 0, everyone can receive the targeted therapy with TDXT. So this is the one more, the Korean Pearly trial. So this, I think most of us already using carboplatin with anthracycline and taxane as an adjuvant in high risk patients with triple negative breast cancer who are not eligible for keynote 522, that is with respect to use of pembrolizumab. So most of us, we are using now the carboplatin. This in this study, the 5-year EFS in the carbo group was 82 versus 75, and also with a good hazard ratio of 0.67. And 5-year survival data is also showing 90 versus 87%, approaching a statistical significance. So except for increased cytopenias, the toxicities were similar with a little higher discontinuation rate with carbo, that is around 2.8 versus 0.9%. I think we have to add carboplatin for all our triple negative high risk breast cancer in the neoadjuvant or adjuvant setting. TSOPEC study, this was presented by Dr. Tamojit. So earlier we were keeping in mind the cross regimen for all our adenocarcinoma. Now that is out. So for all our patients, we use the FLOT regimen with the overall survival benefit, good benefit of 66 versus 37 months. And also the pathological complete response also improved almost 6%, 19 versus 13 months. With post-operative morbidity was as expected in similar both the groups. So now FLOT is the treatment of choice for all patients with adenocarcinoma GE junction. So we may not consider the patient for neoadjuvant CTRT followed by surgery. So this is Dermanotkin study group HT21 trial, the BRCAD. This we have already discussed last 30 minutes or 1 hour with a good PFS benefit of 94 versus 90 months. Then Nadina trial, this was presented by Dr. Rajiv. So that is showing the neoadjuvant Nivo EP followed by surgery and further observation. Actually has done a very good job with a 12 months improvement in event-free survival of 87 versus 57% at 12 months. So the patient, you don't have to receive the adjuvant nivolumab. So definitely it is going to be very, very cost effective for all our patients with melanoma with the node positivity, and even with the BRAF mutated melanoma, it is showing the good benefit. So this is the one last study with respect to the supportive care. So with the use of oxybutynin for hot flashes in men or with androgen deprivation therapy for their prostate cancer. So only 81%, 81 patients were included. So in this, oxybutynin was used 2.5 or 5 mg twice daily versus placebo. So with the use of oxybutynin, there were fewer hot flashes per day. And I think this may need further evaluation. This is one of the study which may we have to do in a large setup to definitely find out the outcome of this. Thank you very much. Thank you one and all for all your presence. I hope we have covered almost majority of the abstract which are practice changing for us. So this will hopefully will benefit all of us. From tomorrow, we can maybe need to change our practices based on the updates. That's all about the medical oncology. That is very important. I would like to thank our academic partners, AstraZeneca, Roche, Novartis, Torrent, Iris Pharma, Samarth Life Science, NATCO, and RPG Life Science. So I would like to thank all the sponsors. So who have really helped us getting all the material and even the speakers. So thank you one and all, and also the Horizon. Thank you very much, Horizon Conference Management Limited. Thank you very much for all your technical support. So thank you one and all.
Thank you so much, sir. Thank you, Lokesh sir.
Thank you, Gitika. Thank you everyone for joining. Thank you, Vishal, and thanks to support team for 2 days excellent academic sessions which goes on. So